Hello? Naririnig niyo ba ako? Can you hear me? Hello, naririnig niyo ako? Good evening sa inyong lahat. At dahil September na, Merry Christmas na din. No? Merry Christmas din sa inyong lahat. Okay, let's start. Hindi na tayo tatagal. Topic natin ngayon is psychiatric nursing. Okay, so pag magdi-discuss tayo ng psychiatric nursing, ito yung ating papag-usapan. Yung mga most commonly tested questions in NCLEX when it comes to your psych nursing. Okay, first, ano yung laging natatanong sa psych? Number one is your THERACOM, your therapeutic communications. O Merry Christmas, Edna. Okay, therapeutic communication. So therapeutic communication, ito yung mga may answers na may quotation mark, no? How do you best respond to this patient? Laging natatanong yan sa NCLEX. Next would be your psychopharma. Okay, psychopharm. Lalong-lalo na yung mga antipsychotics natin, no? Mga antidepressants, mga anxiolytics, mood stabilizers. And lastly, yung actual psych nursing o yung mga psych disorder. Okay? So, ang first topic natin would be therapeutic communication. In your therapeutic communication, we will discuss the nurse-patient therapeutic relationship. Okay? In your nurse-patient therapeutic relationship, meron tong tatlong phases: orientation, working, resolution. Okay? So, if yung napag-aralan nyo dati, may 4 phases, no? Huwag mo na yung isipin. Hanggang tatlo na lang tayo para mas mabilis. Okay? So, in these 3 phases, meron tayong mga keywords na kailangan malaman. No? Mga keywords. So, orientation phase, ano yung keyword natin na kailangan malaman? Before that keyword, okay? So, the orientation phase starts when you meet the patient. No, when you the first time you meet the patient, the first time you meet the client. And it ends when you identify a problem. Okay, when you have identified a problem. Okay, so let's go to the keyword. Ito ang keyword natin, teach. Teach. Anong ibig sabihin ng teach? Acronym yan siya. T is for trust and rapport. So if you encounter a question asking you, no, which of the following belongs to the orientation phase? Pag may nakita kang trust, rapport, diretso na yan, orientation phase na yan. Next, E means environmental setup. No, setting up the environment. So anong ibig sabihin nito? Setting up the environment. No? Ibig sabihin yan, no? Ikaw hahanap ng schedule, no? Ikaw hahanap ng area, kailan kayo magkikita, every Saturday, Sunday ba, etc. Okay? Setting up the schedule. Okay? Setting up the environment. Okay. Next, A. A is to assess strengths and weaknesses. So kung na-encounter mo yung word strength, weakness, okay? Diretso na yan sa orientation phase. Yan yung keyword mo. C is to help the patient communicate. No? Help the patient communicate. Hindi pala. C is to contract signing pala. Contract signing. So, contract signing means that the patient accepts, no, na yung nurse-patient therapeutic relationship. And lastly, H, ito yung help the patient communicate. Okay, so yan yung mga keywords natin. No? Pag nakita mo tong mga words na to, contract sign, strengths, weaknesses, trust rapport, set up environment, set up schedule, immediately isipin mo yung orientation phase mo. Next, sa working phase, ang keyword mo is goals and feelings. Okay? Any sentence or any phrase na nakita mo may word na goal or feeling, exploration of feeling, sharing of feeling, examine feeling, ano pa, no? Determining short-term and long-term goals. Pag nakita mo may goals or feelings, diretso na yan, working. And lastly, yung resolution phase. Okay? In the resolution phase, okay, it starts when the identified problem has been solved. No? Identified problem has been solved. Okay? And it ends when the relationship ends. So, hindi na kayo makikita ni patient. Okay, wala yan digestive secretion, tanggalin nyo yan. Yan. Okay, so anong keywords natin sa ating resolution? Ang keywords natin dito is any word that is related to autonomy. Okay? So promoting patient self-care, autonomy yan. Promoting patient independence, autonomy pa rin. Promote patient's autonomy. So anything that has to do with autonomy, that is your resolution stage. Okay, so yun lang yung tatandaan natin ng mga keywords. Okay? So, what is the common problems sa ating nurse-patient therapeutic relationship? Ang common problem natin sa nurse-patient therapeutic relationship is kahit na nasa relationship, ayaw pa rin nila. They are resisting. Resistance is one of the most common problems. So what is resistance? This can be conscious or unconscious. Opposition towards the relationship. The patient is opposing the relationship. And how do they do this? Diba? They can be argumentative, nakikipag-argue sila. It could be interrupting, or ignoring. Maybe you have encountered patients that are like this, argumentative, ignoring, denying, interrupting. So those patients are still resistant to the nurse-patient therapeutic relationship. Okay? Another problem would be your transference. So what is this transference? This is the act of the client, unknowingly transferring feelings to the nurse. And these feelings is usually deep, intense, and unconscious. Okay, so meron siyang mga nararamdaman na feelings towards sa kanyang nurse. And the reason kung bakit siya nagkaka-develop ng feelings na to, it is usually some unconscious thing going on. It may be because the nurse is reminded, the patient sees the nurse as someone like his mother, ganyan, or a father figure, a friend, kaya may nararamdaman siya mga feelings na to. So tatandaan mo, transference is when the client starts to feel something to the nurse. This is normal. Normal lang to. Okay? To prevent this from becoming bigger, you have to remind the client that the relationship is a professional relationship. Okay? Professional relationship. Kasi baka, magka-developan sila. And that's not good. Hindi na yan therapeutic. Okay? Now, what is countertransference? Pag countertransference, opposite lang. Okay? The nurse is starting to feel a deep, intense, unconscious feelings or emotion towards the client. Bakit? Because the client might remind the nurse, yung client parang girlfriend niya, parang boyfriend niya, parang father figure, mother figure, etc. Okay? So kabaliktaran to. Tatandaan natin that countertransference is not normal. Hindi to siya maganda. Okay? When the nurse starts to feel something to the client, it's no longer normal. To combat this, ang ginagawa dapat ng nurse is to perform self-introspection. Okay? So, iisipin ni nurse, bakit ba ako nagagalit sa pasyente na to? Bakit ba, annoyed ako sa pasyente na to? Bakit ba in love na ako sa pasyente ko? So, yung tatanungin dapat ni nurse ang sarili niya, it will perform introspection. Okay? So, any questions with the nurse-patient therapeutic relationship? Any questions sa nurse-patient therapeutic relationship? No questions, basta tatandaan nyo yung mga keywords. Kasi sometimes may mga tanong sa NCLEX, which of the following actions belong to the orientation phase? Which of the following actions belong to the late phase or the last phase of your patient-therapeutic relationship. Basta yung keywords lang. Pag nakita mo yung goals and feeling, diretso working. Pag nakita mo na sa teach siya, may trust rapport, environment, schedule, strength, weaknesses, orientation. Pag may nakita kang word na autonomy, independence, self-care, or any synonymous doon, resolution agad yun. Okay? So if there are no questions, let's proceed to your therapeutic communication. Okay, so no, you might have encountered this question before, di ba? Itong mga tanong na to is, how do you respond to this patient? Parang ganun, or what would be the initial response to the patient? And usually the answers are in no quotation marks. No, naka-quotation marks yung answer. Those types of questions are usually your therapeutic communication. Now, itong table na to, ito yung aking fastest way of determining the right answer for this patient. No? Ito yung step-by-step process ko. So, if weakness mo yung therapeutic communication, how to properly respond to a patient, okay? So, ito na yung opportunity mo. So, first, tatanungin mo, is the patient psychotic or non-psychotic? Is the patient psychotic or non-psychotic? The patient is non-psychotic kapag meron siyang insight. Tinatawag nating insight. When you say insight, it means that the emotion, no, what the patient is feeling, the mood, is congruent to the situation. For example, nagalit si patient kasi hindi siya binalikan kagabi ng nurse niya. Diba? That is normal. Magagalit talaga ang pasyente pag hindi mo pinupuntahan. Okay? Another example, umiiyak si patient dahil namatayan siya ng anak, no, ng newborn. That means that congruent yung kanyang emotion. So, connected yung kanyang emotion sa situation. That's what you call good insight. Next, aside from having good insight, the patient is also, no, reality is intact. Reality is intact. When you say reality is intact, ibig sabihin, si patient, wala siyang hallucination, delusion, and illusion. Okay? Wala siyang hallucination, delusions, or illusion. That means an intact reality. Kapag yung patient mo maganda yung insight niya, kapag yung reality niya is intact, ibig sabihin, non-psychotic si patient. So for non-psychotic patient, the best answers would be reflection, clarification, no restatement, or yung mga tell me more, how are you feeling? This must be difficult for you. Okay? So, hindi tayo masyado magfo-focus dito. No? Later, meron naman tayong mga general rules kung non-psychotic si patient. Okay? Basta tatandaan nyo, the best response always has your acknowledged feeling. The best response always has acknowledged feeling. Okay? So what is acknowledged feeling? For example, si patient umiiyak kasi namatayan siya ng newborn. Okay? If you're going to say acknowledged feeling, sasabihin mo, you look depressed or you look sad, you seem sad, ganun. So you are acknowledging what the patient is feeling, and usually that would be the best response. Meron kang acknowledged feeling. Okay. So for non-psychotic, there's no problem there. No, as long as you are therapeutic, wala akong problema. So diretso na tayo sa mga psychotic patient. Okay. Paano malalaman kung psychotic si patient? Of course, wala siyang insight. Okay? Ibig sabihin, namatayan siya ng newborn pero tumatawa siya. No? So the emotion and the situation are not congruent. Okay? Na bangga yung kanyang paa sa table tapos binugbog niya yung asawa niya. Di ba? The emotion and the situation are not congruent. That is poor insight. Next, aside from having poor insight, you have poor reality. So if you have poor reality, the patient is either hallucinating, having delusions, or having illusions. No? Hallucination, delusion, and illusion. Okay, so pahapyaw lang na discussion. When you say hallucination, di ba? Later we will build up on this. When you say hallucination, this is a sensory experience without stimuli. This is a sensory experience without stimuli. Ibig sabihin, you are hearing something, but no one is talking to you. You are seeing something, but nothing is there. So it is a sensory experience, but no external stimuli. Okay. Ano naman ang delusion? Delusions, no? These are fixed beliefs or ideas that is beyond logic. Hindi na siya logical. No? And delusions can come in a lot of ways. Pwede ka maging paranoid delusion. No? You think someone is going to kill you, paranoid delusion yon. No? Or sa tingin mo sa sarili mo, ikaw yung pinakamayaman, no? Pinakagwapo, ganyan. Tawag yan is grandiose delusion. Diba? So it is a fixed belief that is beyond logic. And last, illusion. No? So in illusion, this is misinterpretation of an external stimuli. Okay? So when you're going to differentiate hallucination sa iyong illusion, okay, ang hallucination, walang external stimuli, pero meron kang sensory perception. Okay? Sensory experience. Sa illusion mo, there is external stimuli, but you misinterpret it. The usual example is when someone, like a doctor, walks into a room, tapos meron siyang stethoscope, tapos sinabi mo, Doc, why is there a snake on your neck? Oh, so there is an actual thing around the doctor's neck, it's the stethoscope, but you misinterpret it. That's what you call an illusion. Okay, so if si patient mo is psychotic, anong next gagawin natin? Next mong gagawin is you have to determine, is the patient functionally psychotic, demented psychotic, or delirious psychotic. Okay? So, someone who is functionally psychotic, tinatawag natin sila as functional psychosis because if they take the proper medications, okay, they can function in society 100% pag umiinom sila ng gamot. So, sino tong mga patients na to? These are usually patients with common chemical imbalances. No? Like your schizophrenia patient, imbalance sa dopamine, bipolar patients, ganyan. So commonly, mga schiz and bipolar to sila. Okay? We call them as functionally psychotic. So if you have determined that your patient is functionally psychotic, how do you answer them? First, dapat acknowledge the feeling. Okay, let's set an example. Now, for example, you have a patient, tapos sabi niya, there are zombies in the pantry. I'm not going to eat there are zombies in the pantry. So first, acknowledge the feeling. I understand you're afraid. So you have acknowledged the feeling. Next, present reality. But there are no zombies in the pantry. Okay? When you present reality, that is merely stating what is real. No? What is real. Sasabihin mo sa kanya ano yung totoo. Sometimes, presenting reality, no, pinapakita dito kung what is real and what is not real. No? Real versus not real. Okay? Ano ibig sabihin yan? Another way of stating it, those are not zombies, those are nurses. You are telling them what is not real from real. That is what you call presenting reality. Then you set or enforce limit. Go to the pantry and take your meal. O ganon. That is the best way to respond to a patient with schizophrenia or bipolar. First, acknowledge the feeling. I understand you're afraid. I understand you're sad. You look angry, etc. Present reality. Teach them what is real from not real. And then set limits. Sasabihin mo sa kanila what they have to do now because you're setting limits na. Okay? So next, demented tayo. Demented psychosis. Someone who is demented psychosis means that their brain is actually damaged. Yung utak mismo nila, bulok na. Okay? They are suffering from chronic brain injuries, no, chronic brain damage, and their brain is slowly deteriorating. Can you name a condition, no, or a disease that falls under demented psychosis? Can you name a disease? that falls under demented psychosis? Alzheimer's. Okay? Alzheimer's, the brain is slowly deteriorating, and pag tinignan mo yun sa autopsy, makikita mo na yung kanyang mga valves, malalaki na. So yes, Alzheimer's. Aside from Alzheimer's, ano pa? Dementia is a tawag yan, general term, no? That's a general term. Alzheimer's falls under dementia. Okay? So ano pa? There is actual brain damage. Isipin mo yung utak, affected talaga siya. Chronic drug addiction, hindi din. Chronic drug addiction. So, drug addiction, secondary to something na siya. No? Okay, so, another example would be stroke. Diba? If you have stroke, your brain is damaged. Nasira talaga yung brain. Okay? Very good. Traumatic brain injury, yan. Mga ganun. Think of the brain that is affected. Cancer. No, may cancer ka sa brain mo. Affected talaga yung brain mo. So, patients who have demented psychosis have actual brain damage or sira talaga yung utak nila. And you can't cure it. Another example, rabies. Diba? Rabies. Rabies, their brain is slowly deteriorating. Yan. So, most common dito is Alzheimer's kasi. Diba? Alzheimer's. So, how do you answer a patient who has demented psychosis? Okay, first, acknowledge the feeling. Hindi talaga to siya mawawala, no? Kasi it is always good to acknowledge how the patient feels. Okay, let's give an example, no? Your patient diagnosed with Alzheimer's disease is awakened at 4 in the morning, is trying to leave the facility, and is telling the nurse, I have to go because I have a meeting with President Joe Biden. Okay. So, first mong gagawin is acknowledge the feeling. So, how do you acknowledge the feeling? Tell the patient, that seems important. Okay, I understand that that is important. And then you redirect. Okay, you redirect. But if you have a meeting, shouldn't you be going to sleep? Ganyan. And then promote safety. Let's go back to your room so you can sleep. Ganyan. Okay? So when you answer these types of patients sa demented, you cannot teach them what is real. That's why hindi mo makikita yung present reality dyan. Because they can never learn what is real. Hindi nila malalaman kung ano ang totoo. Their brain is not healthy enough to learn what is real. However, you can orient reality. Okay? Presenting reality and orienting reality are two different things. Pag sinabi mong orient reality, we are talking about time, no? Place, person. For example, it's 12 o'clock, no? It's 6 o'clock. I'm your nurse. This is a hospital. Okay, that's orienting reality. But when you're comparing it to something that is not real, nagiging na siyang reality presentation. This is a hospital, not a cave. Oh, reality presentation na yun. I'm your nurse. No? I'm not going to kill you. Reality presentation na yan. Okay? But if you're just telling them ano yung orientation ngayon, time, place, person, that's orienting reality. Okay, last, no? Delirious. So, si delirious, no, these patients have temporary psychosis. Okay? Meron silang acute or it's usually secondary to a disease, a condition. So, kanina may nag-mention dyan, drug addiction. Yes, that is a common example of delirium. No? Substance abuse. Diba? Pag nag-aabuso ng mga different substance, pwede sila mag-show ng psychotic symptoms, pwede sila mag-hallucinate, pwede sila magkaroon ng illusion, etc. However, once the substance leaves their body, nawawala na yung kanilang psychosis. Okay, aside from drug abuse, what are other conditions that can give the patient temporary psychosis na magiging silang delirium? Ano pa kaya? Okay, encephalopathy, very good, no? Uremic encephalopathy, okay? Hepatic encephalopathy, pwede. Okay, dahil sobrang taas ng kanilang mga ammonia, aakyat sa utak, then mag-show sila ng signs ng mga hallucination, delusion, illusion. Pero pag nawala na yung ammonia, normal na naman sila. Ano pa kaya? Post-anesthesia. Even during anesthesia, pwede din. Diba? During anesthesia, pwede sila magkaroon ng hallucination, delusion, illusion. But once the anesthesia leaves their body, wala na, okay na naman sila. Ano pa? No? Among elderly, di ba, infection. Common sa mga matatanda. For example, among elderly patients na nagka-UTI, they start to show hallucination, delusion, and illusion. No? Pero, once cured yung kanilang UTI, nawawala din yung kanilang delirium. So, how do we answer these types of patient? First, acknowledge the feeling. Hindi talaga siya mawawala. Dapat nandyan siya always. Next, you can perform reality orientation. Pwede mo sabihin, I'm the nurse, that's the doctor, this is hospital, etc. Then, you treat the underlying condition. No, you can even tell the patient that his psychosis is temporary. And once na-heal na siya, mawawala na yun. And lastly, promote safety. Okay? Promote safety. So, any questions? Any questions dito? Yes, pwede, no? Kung meron kang chronic kidney disease, ay hindi, ang CKD, oo, it will fall under delirious, no? Kasi ang patients na may CKD, di ba, kailangan silang dinadialysis para tanggalin yung excess na nitrogenous waste. Pag natatanggal yun, normal na naman sila mag-isip. Pero pag dumadami, balik na naman yung kanilang delirium. Ganon din with liver cirrhosis. Diba? Pag hindi sila nakainom ng lactulose, aakyat yung kanilang ammonia. Bigla lang, psychosis na naman. After natanggal na yung ammonia nila, no, they excrete it out, wala na namang psychosis. Basta ang tatandaan natin, ang delirious is temporary. Yung psychosis nila is usually tied to a disease. Once the disease is cured, once a condition is changed, nawawala na naman yung psychosis nila. Okay? Any questions? Ito, may tanong ako. No? Ang Wernicke-Korsakoff syndrome, saan mo ilalagay? Demented or delirious? Or functional? Saan mo yan ilalagay? Wernicke-Korsakoff. From the name itself, malalaman mo na kung asan siya ilalagay. Pag makikita mo lang yung word na yan, alam mo na dapat it belongs here. Pag sinabi mong syndrome, ba? Syndrome is a combination, no? It is a combination of different diseases that is lifetime in nature, no? Parehas ng diabetic mellitus. Diabetic mellitus is a syndrome. So it should fall under demented. Okay? So ang Wernicke-Korsakoff syndrome, 'di ba, nakukuha to ng mga alcoholic. What happens to these patients is because they're drinking so much alcohol, thiamine and folic acid level falls below normal, which severely and permanently affects their brain or neurocognitive. So permanent brain damage na siya. Okay, so it should belong in your demented. Okay? So any questions? No questions? Okay, sige, let's continue. So in general, ito yung mga do's and don'ts natin. Do's and don'ts of therapeutic communication. Do, acknowledge the feeling. No? Paulit-ulit ako sa acknowledge the feeling kasi importante yan. Sometimes this is all you need. No? Ito lang yung kailangan marinig ni patient. Kailangan lang nilang ma-validate kung ano nararamdaman nila. Next, do present reality. Now, this is usually for functionally psychotic patient. Do orient reality. This one is for all. No? Pwede mo itong gawin sa lahat. Do promote safety. Okay? Of course, no? You have to know how much degree of safety are you going to promote. Diba? Tatandaan natin that restraints, chemical or physical, is normally last case scenario mo na yan. Next, do de-escalate the situation. For example, may galit. Of course, hindi natin papatulan yon. No? As much as possible, we try to de-escalate the situation so they remain calm. So how do you do this? How do you de-escalate the situation? O sige, sa inyo, no? Maybe you have experienced this in the hospital. Maybe not even in the hospital. How would you de-escalate the situation? How would you de-escalate the situation? Anong gagawin mo? If someone is arguing, nagrereklamo, galit, irate yung pasyente, kahit hindi pasyente, very good, calmly. Okay? Calm dapat ikaw. Distract the patient, huwag naman. No? What if may patient ka na nagsabi na walang pumunta na nurse dito para magbigay ng gamot? Hindi mo naman sasabihin, mamaya na yan, nood mo na tayong TV. Di ba? Huwag mong gawin yan. So approach the patient calmly, ano pa? No? Sige, what about your posture? Ano mo dapat ang posture mo? You should maintain a okay, sige, eye contact. O, paano ang eye contact natin? Should we maintain eye contact or intermittent eye contact? Anong gagawin mo? Maintain eye contact or intermittent? Isipin mo ha, may galit kang kausap. Tititigan mo ba siya? Or intermittent? Pabalik-balik. Ano man? Very good. Intermittent, no? Di ba pag galit ang tao, pag tinititigan mo, di ba mas magagalit? O intermittent eye contact. Okay, when it comes to posture, paano dapat ang posture natin? It should be open and relax. Now, when you say open posture, do not cross your arms, put your arms in your pocket, lagay ang kamay sa likod. Dapat open with your palms open, then open and relax. And of course, your tone of voice is normal. Do not raise, wag din masyadong bababa. And always allow the client to voice out. Allow the client to voice out. No? So papakinggan natin siya. Next, set and enforce limits. Okay, so this time, hindi na pwedeng pagbigyan si client. We have to enforce limits. And how do we do this? To enforce limits, you describe the consequence of their behavior. No, describe the consequence of their behavior. For example, if you continue to do this, we will remove you from the day room and place you into back to your room. O ganon. So, describe the consequence of their behavior. If you continue to bang the table, we will call security. O ganyan. Okay? Lastly, redirect and distract. Now, this one is for demented patients. Patients with Alzheimer's. Ganyan. And lastly, use your therapeutic communication. Okay. Ano na naman ang mga don'ts natin? Don't belittle, negate, or devalue. Okay? For example, may umiiyak, malungkot. Hindi mo naman pwedeng sabihin, everyone feels that way. No? Lahat tayo nalulungkot. No, that is belittling. Next, do not show approval or disapproval. This is blatantly agreeing or disagreeing with the patient. No? Sasabihin mo, I agree. I disagree. That's wrong. Okay, bakit mali daw yan? Now, ang rationale is that when you agree or disagree with the patient, it changes the patient's behavior not because the patient wants to change, but because the patient changes based on your opinion. No? So, hindi siya nagbabago dahil gusto niya magbago, pero nagbabago siya dahil sa sinabi mo. Okay, next. Do not challenge the patient. Challenging the patient is demanding proof. No? Demanding proof or showing proof. Now, ako, common to siya when it comes to Alzheimer's patient. No? Nagre-reklamo na, hindi mo ako pinakain. No? Tapos ang gagawin ni nurse, sige, punta tayo sa CCTV. Panoorin mo sarili mo doon na kumakain ka. That is challenging the patient. Do not challenge the patient. Showing proof or demanding proof. Next, do not avoid the patient. So, no, don't leave the patient alone. Huwag niyong papabayaan. Don't answer literally or logically. This is common when answering tawag yan, hallucinations, delusions, or illusions. No? Instead of saying na those are not um, those are not uh, zombies, those are nurses, no? Aansaran mo sila logically. Those are not zombies because the zombie virus does not exist. O parang ganun. So do not answer logical, do not answer literal. Okay? Those are doctors, not murderers. Oh, that is answering literally. That's wrong. Okay, next. Do not stereotype. Stereotyping is putting a group of people, no, in an oversimplified belief. For example, all black peoples are always late when it comes to clinic visits. All Hispanics are late when it comes to hospital visits. Ganon. So you are oversimplifying. And lastly, do not test a patient. And when you say test, that is asking why. Do not ask why. Also, don't give false reassurance. No? Do not give false reassurance. Any questions? Any questions? No questions? Okay, let's answer the following. A patient diagnosed with Alzheimer's who was eating in the kitchen is suddenly hiding under her pantry table. She tells the nurse, "Those walking across the corridor are communist spies from the Cold War, come to take me away." The best response of the nurse would be, first question, is the patient psychotic or non-psychotic? Ano yung pasyente na to? Psychotic or non-psychotic? Psychotic. No? Kasi meron siyang, ayan o, delusion. No? Paranoid delusion. Next question. As anong type of psychotic patient? Functional, demented, delirious? Demented kasi meron siyang Alzheimer's. Okay. So, answeran na natin. What would be the best answer? Okay, ang daming answer. Ibig sabihin, hindi ginamit yung aking strategy. Okay, ano yung strategy ko? Diba? Dapat number, very good. No? Sige, one by one. Bakit mali si number one? They are not spies. They are nurses. Anong tawag mo dyan? When you compare something real from not real, what do we call that? They are not spies. They are nurses. That is presenting reality. Can you present reality to someone who is demented? Yes or no? No. Next. Si number two. Okay? The Cold War was years ago. You're in a hospital. We will keep you safe. The Cold War was years ago. Anong tawag natin dyan? That is answering the patient logically or literally. Correct. No? So that is answering the patient logically or literally. Mali. O si number 3. Bakit mali si number 3? Ano yung word na nakalagay dyan? Disagree. Di ba? You should never agree, disagree. You should never approve, disapprove. You should never give positive remarks. You should never give negative remarks. So the best answer would be number 4. That sounds frightening. Acknowledge feeling. Your room sounds like a safe place to be. Distract. Let's go somewhere where you feel safe. No? Safety. Okay, naintindihan ba bakit si number 4 ang best answer? Yes. Okay, next tayo. A 54-year-old is admitted to the ED by the significant other. Handover by paramedics, the client is received on a gurney with physical restraints applied. According to SO, the client suddenly became confused and agitated at around 1900. SO started shouting and throwing. Currently, the client is shouting at the nurse, "You're all demons trying to get me." Lab results show that total bilirubin is high, AST is high, ALT high, serum ammonia high. Okay, so psychotic or non-psychotic? Very good, psychotic. Okay, what type of psychotic? Delirious. Kasi mataas yung kanyang serum ammonia. Baka meron siyang hepatic encephalopathy. Okay, what would be the best answer? Excuse me. Correct answer is letter C. Okay? So letter A, mali. We are not demons, we are nurses, and we are going to restrain you to keep you safe. You don't need to tell them, no, you don't need to present reality sa kanila. Delirious sila, not functional. I know you are afraid, but if we are demons, then why? O, mali na agad. There is no such thing as demons. You are admitted here due to a disease. Maganda na sana pero walang TLC. Walang acknowledge the feeling. Please behave. If you will not behave, we will call security. Oh, 'di ba? Bakit ka patatawag ng security? The patient is already restrained, no? You have received the patient physically restrained. So, overkill na kung tatawag pa tayo ng security. Okay, mali din. Please acquire doctor's order for chemical restraint. Grabe, physical restraint na si patient, tapos papatulugin pa natin siya. So, mali. No? The best answer would be letter C. I understand you are angry, but your fear will go away as you get better from your illness. Acknowledge the feeling. Okay? Sige, next tayo. A 28-year-old client with a schizoaffective disorder stated she was seeing ghosts darting back and forth across the hallway. Client was prescribed haloperidol for positive symptoms. During periods of depression, client states that he lacked the energy to drink the medication. O, balikan natin mamaya. Client was seen by the nurse and the LPN awake, sitting on chair. Client was observed to be mumbling to herself. Client pointed to the nurse and the LPN, stating, "The nurse here are plotting to kill me." Okay. Psychotic, non-psychotic. Malamang psychotic. What type of psychosis? Functional. Paano natin nalaman na functional? Again, when they are medicated, they get better. Okay, so functionally psychotic, which would be an appropriate, which would not be an not appropriate response, not to the client statement. Okay, number 1, have you taken your morning medications? Appropriate or not appropriate? This one is appropriate because this will determine, no, kung umiinom pa ba siya ng gamot. Yan. Next, No, I don't think they will kill you because they are healthcare providers and not murderers. Not appropriate. Don't answer a client literally. That would be frightening. But we are your nurses and they are not plotting to kill you. Kompleto, meron kang acknowledge the feeling, meron ka pang presenting reality. Why do you think the doctors are trying to kill you? Why? O, mali na agad. This might be stressful for you. We will leave you be and come back when you are ready to talk. This one is not appropriate. Do not leave the patient. Yan yung sinasabi ko, no? Yung avoiding the patient, yung word na leave. Sometimes they make it sound like parang malambing, no? Parang may ginagawa kang tama. But you should never leave the patient, especially if they are having, no, psychotic symptoms. Dapat hindi natin papabayaan. Okay? Should not leave the patient. Any questions sa ating mga sa ating tawag niyan, therapeutic communication? Any questions? Sige, balikan muna natin. Okay na ba to? Okay na, sige. If there are no questions, let's proceed to aggression and grief. Okay, aggression and grief. So what is anger? What is aggression? Anger is a response to being hurt. No? It is um, it is an alert for us when there is actual or potential threat. Okay? 'Di ba? Ano yung saying na hurt people? O ganun din, 'di ba? Pag sinaktan ka, mananakit ka. We have to learn that anger is not a primary emotion. It is an autonomic response. Ibig sabihin, you feel anger because you are, no, in a flight or flight mode. For example, no, galit ka sa isang tao, it's because this is an autonomic response to you. No, fight or flight mode ka. Hindi siya emotion. Okay, it's not an emotion. Okay? Additionally, the expression of anger, no, the expression of anger, that one is learned. Okay? So if you have ever been angry, tapos ang ginagawa mo is manununtok ka ng pader, tung, you probably learned that from someone. No? If you have ever gotten angry, tapos ang ginagawa mo is nag-stonewall ka, no? Hindi ka nakikinig, ini-ignore mo yung tao, you probably learned that from someone. Because anger, no, the expression of it is learned. We learn it from usually our parents. Okay? Usually our parents. Now, normal anger, okay, when your anger is normal, it can be used to help us, no? It can be used as a creative force. Diba? Have you ever been angry to a point na ginawa mo lahat ng trabaho mo para hindi ka na mapapagalitan? That's normal. However, abnormal anger is always destructive. And it is disproportionate. No? Destructive and disproportionate. Ibig sabihin, kung ano yung nangyari, hindi proportionate yung iyong pagka-react doon. So that's what you call poor insight. Okay, next, aggression. So aggression is a behavior that is intended to punish someone. Okay? We have different types of aggression. We have active aggression. No? This is an impending sign of assault. No? Active aggression is an impending sign of assault. This is an overt sign. No, overt. So ito yung ano ba, sumisigaw, no, slamming a door, slamming a table, ganyan. Threatening someone, that's what you call active aggression. It is an overt sign. Okay? Passive aggression naman is an indirect expression of anger. No? or you express anger in a subtle way. And lastly, lateral aggression is a form of aggression commonly found in workplace environment. Lateral aggression is a common problem no, in the hospital among nurses. Maybe you have already heard the expression, nurses eat their young. No? Kinakain daw natin yung mga bagong hire. Diba? That's a common trope, lateral aggression. So, lateral aggression usually occurs, no? It is non-physical, ha? This is non-physical, okay? But it is still considered as workplace violence. Workplace violence siya because it creates a hostile environment sa trabaho. No, these behaviors create a hostile environment sa trabaho. Power tripping, pwede, no? That could be a sign of lateral aggression. So have you ever felt of not going to work kasi nandyan si workmate that will do this and do that? That could be a sign of lateral aggression. Common among women, common among nurses, no? Hindi naman sa babae. Okay? Among nurses. Common sa atin. So, paano natin to siya ma-control? No? Ganon head nurse namin. Di ba? Madaming example. Madaming, siguro lahat ng nakatrabaho na dito, it's not common, hindi lang to common sa hospital, it's common in all workplaces, no? But mas common talaga siya sa hospital. Yan. Ang example for this one, no? Example for this one would be your, di ba may mga patients that are considered toxic? For example, may mga group of patients doon, tapos may mga toxic. For example, newly hired ka, tapos lahat ng patient na nalagay sa'yo, toxic. So, hindi ka na makaka-uwi, hindi ka na makakakain. That's a sign, no? That's a sign of lateral aggression. Okay, bullying, yes. No, lateral aggression, that is another word. Ang other name niya is workplace bullying. Kasi kung men may threat ng physical retaliation, no, that's not true. No? Kung asan mo nagtatrabaho, may nagsuntukan, dalawang nurses, babae, it doesn't matter. Now, you have to understand that lateral aggression, no, is non-physical. It's a form of workplace bullying. Creative force. Okay? This is creative. Sorry. No? Yan. So, ano daw yung gagawin natin if there is lateral aggression kung binubuli ka sa trabaho? Okay. So, ito yung ating interventions. No? Intervention for lateral aggression. O sige, anong example nyo? Kapag binubuli sa trabaho, ano dapat ang gagawin? No? And we will try to connect it with our lecture. Confront, very good. No? You call off the behavior. Call off the behavior. Bakit? Because silence implies tolerance. So, the more ka tahimik, ibig sabihin, tinotolerate mo yung ginagawa sa'yo. Okay, very good. So, when do you call off the behavior? No? ASAP. As soon as possible. Huwag mo nang patagalin. Pag feel mo na may ginawang mali sa'yo, call off mo na agad para hindi na maulit. Ano pa? What are other ways, no, interventions natin for lateral aggression or workplace bullying? Ano pa? Isumbong, correct, no? Saan mo isusumbong? Follow the chain of command, no? Report to head nurse, yes, no? Basta follow chain of command. So, isusumbong mo sa higher up. Kung hindi madala doon, another higher up, and another higher up, another higher up. Ano pa? No? Ano pa? Dapat documented lahat. Proper documentation. Para may proof ka. Pag nagsumbong ka, dapat may proof ka. So, proper documentation. Document mo lahat ng ginagawa sa'yo. Ano pa? O last, kung hindi nadala sa sumbong, what if yung head nurse yung kalaban? What if yung nurse manager ang kalaban? Okay? Kanino dapat siya isusumbong? Sugurin? Grabe naman, wag mo na sugurin. Sumbong mo kay mama. Sumbong mo sa mama mo, 'di ba? Kasi ang mama mas malakas yan kahit kanino. Sumbong mo sa mama mo na hindi marunong mag-English, pero pag may kaaway, mas magaling pa siya sa Amerikano. Ganun, galing na siya mag-English. Don't you know this? Yan ang mama mo. Okay? Sumbong mo kay Tulfo. Isa din yan. Di ba? Nakita mo si Rendon, naging mabait na siya after sinumbong kay Tulfo. Joke, wag mo isumbong sa kanila. Sumbong mo sa OSHA. Okay? Sumbong mo sa OSHA. OSHA or Occupational Safety Health Association is a third party. No? May mga nurses din under OSHA. Okay? And part sa OSHA, no, part sa OSHA is, tawag yan, is dealing with workplace violence. So third party to sila yung last mong isusumbong. Asserting boundaries, same as calling behavior, yes, no? Asserting boundaries, calling behavior, for example, no? Pininch yung iyong puwet, di ba? That's sexual assault. Oh, so tell them na wag mo yung gagawin, blah blah blah. Tell them that's wrong. Ayan. Okay? So, yan ang gagawin ha. Ito yung step by step, no? According sa NCLEX. Call out the behavior as soon as possible. Follow the chain of command, proper documentation, and of course, if nothing works, sumbong mo sa OSHA, Occupational Safety and Health Association. Okay, next. Catharsis. No? Catharsis is a safe yet aggressive expression of anger. Example sa atin dito would be exercising. No? Or yung magpupunit ng papel, tearing papers. Ganyan. Or shouting in a pillow. Ganyan. So it is a safe yet aggressive expression of anger. Catharsis is contraindicated. Indicated for patients that are aggressive. Okay? So any questions with anger and aggression? Any questions with anger and aggression? No questions? Okay, let's continue to your why contraindicated? Because patients who are aggressive cannot control their catharsis. No? They might express it that way, pero usually it bleeds off to something. For example, no? Magpupunit sila ng papel. Eventually, nagiging destructive na yung force nila. Yung pinupunit nila, mga pinupunit nila, mga birth certificate, mga kung ano-ano na lang, di ba? Their aggression becomes destructive. So, hindi talaga siya healthy to promote catharsis. Okay? So, next, pag-usapan natin yung stages of anger. Okay? When it comes to stages of anger, dito natin malalaman kung kailan tayo mag-restrain. Okay? Kasi meron different stages. First stage natin is triggering. No? The patient here is restless, glaring, no? Nakatutok sa'yo. Increase in breathing. Their voice quality usually change. No? Sa sobrang galit nila, no? Baka lumalalim yung boses nila. No? Pag sigaw nila, napipiyok konti. Okay? Ganyan. They are usually pacing, naglalakad-lakad. Escalation. Now, during the escalation stage, they are screaming, no? Swearing, nagmumura. Loss of, no? Problem solving, hindi na sila nag-iisip. Okay? Pag crisis naman, no? Their action is aimed towards harming you. Okay? So, mag-harm na talaga sila. Next, recovery, no? After what they have done, no, usually their body tension decreases, no, and they will go to your post-crisis. They are apologetic. They are crying. They understand what they've done, no, na mali sila. Okay? So in each stage, dapat alam natin yung nursing intervention natin. During the triggering stage, ang gagawin mo is to de-escalate as soon as possible. How do you de-escalate? Diba? Dapat empathetic support, no? Clear, calm, simple statements. Maintain control. Ganyan. Move to a quiet area. Dapat open yung posture. Yung na-discuss natin earlier, yan dapat yung gagawin. Next, during the escalation stage, anong ginagawa? Ano? Pag nagmumura na, pag minumura na tayo. This time, we have to enforce limits. Okay? When we enforce limits, sasabihan natin sila ano ang consequences if they further continue their action. No? During this time, nagpe-prepare na din tayo to show force. No? Nagpe-prepare na tayo to show force. Okay? Next, sa crisis stage. Okay? This time, the patient here is a safety issue because all their behavior is geared towards harming. Naninipa, nanununtok, they might be biting, so therefore dito na tayo magre-restrain. So as you can see, the only time you perform restraint is when the patient is going to harm you. Pag nanununtok na talaga sila. You cannot perform restraint if they are swearing, screaming, ganyan. In your recovery stage, ang ating nursing intervention dito is to assess patient as well as staff if there are any injuries. And lastly, in your post-crisis, we process the incident. Okay? So malamang gagawa tayo ng INR nito, no? And then we document it. Ganyan. No? We document. So, balik tayo dito sa show of force, no? Preparing to show of force. No, ang other name dito is preparing to show determination. Okay? When you're going to show force or show determination, ito yung mag-restrain ka na. When you are going to restrain someone, no, it is recommended na 4 to 6 members daw. 4 to 6 members kasi, no, 1 for each limb. Okay? So that's 4 people. Tapos kung 6, 1 for each limb plus torso plus head. Ganyan. Next, set limits. So sasabihin natin sa kanya kung ano yung mangyayari, no? And then you take hold of the limbs, the 4 limbs, the head and the torso. Yung head and torso hindi na necessary. Okay? Pero pwede yung 4 limbs. And then eventually they will be taken by a gurney. Okay, restrain sila doon and no, if needed, kailangan ng chemical restraints or ibig sabihin kailangan ng papatulugin sila or anxiolytics. Now, this one is of course for psychological patients. No, you don't need to seek your doctor's order as long as no, you can prove that the patient anong ha? Ha? Hindi ako naririnig. Tapos na incident nun, ano? Anyway, you don't need to secure a doctor's order as long as the patient is no, nasa crisis or there is a safety issue. No? So, ibig sabihin, if the patient is going berserk, hindi mo na kailangan mag-secure ng patient ng doctor's order. You can restrain the patient, no problem, pero you still have to secure a doctor's order within 24 hours after restraints. No? After restraints. Last resort, di ba? Oo, last resort ang patient restraint. Okay? So tatandaan natin, no? When restraining a patient, you do not need a doctor's order as long as you can prove that the patient is a safety issue, no? Ibig sabihin, they will start harming somebody, no? Nasa crisis stage na sila. But once the patient is restrained, you still have to secure within 24 hours. Now, you still have to secure within 24 hours. Okay? So, any questions when it comes to the stages of anger? Okay, any questions when it comes to the stages of anger? No questions? Okay, let's talk about restraints. No? Restraints. So restraints can come in two forms, chemical or physical. When it comes to chemical restraints, kailangan talaga ng doctor's order nito kasi medication to. But ang physical restraints, no, you don't need doctor's order as long as the patient is a safety issue. But once the patient is restrained, you have to secure within 24 hours. Okay, within 24 hours pa naman. So what is our acronym? R is require doctor's order. Okay? Except, yung na-explain ko kanina, no? Except if the patient is a safety issue, you don't need a doctor's order, okay, as long as you can secure within 24 hours. Okay? E is for emergency use only. Kung kailangan na talaga. So last case scenario na to. S, it should be the shortest duration and less restrictive principle. So when you say less restrictive principle, of course, when you're going to restrain someone, it will always start peripherally. No, ang i-restrain natin yung mga wrist and legs. Hindi tayo magre-restrain agad sa head and chest. Okay? Peripheral muna. Pwede isang kamay muna, no, dalawang paa, ganyan. Okay? So shortest possible duration and less restrictive principle. Next, we restrain because we want to protect, no? To protect the patient and others. Or we have to renew the order every 24 hours. A, assess skin and circulation. No, assess skin and circulation and also breathing if you are applying a chest restraint every 15 to 30 minutes. Okay? For patients that are restrained, they have to be supervised. Individual supervision is usually required. O kailangan ino-observe sila. And you should never restrain. No? You should never restrain, no, to punish someone. Never use as punishment. T, dapat documented lahat. Total documentation. And lastly, another S, no, seclusion, or yung ilalagay sa isang lugar na walang babantay sa kanya as a last resort. No, yung ilalagay siya sa isang room na siya lang mag-isa, that should be done as a last resort. Okay? So yan ang ating acronym when it comes to restraints. So any questions? Any questions sa ating mga restraints when it comes to anger? Ano yung question? Consent? Anong ibig sabihin? Ano yung question niyo po? From relative? Kumpletuhin niyo naman yung tanong niyo, sir. Consent? From relative. Do you need a consent from relative? Is that what you mean? Hindi na kailangan. Okay? Hindi na kailangan. As long as the patient is seen as a safety risk, you can restrain without consents. Okay? Consent? From relatives. Okay? Seryoso masyado yung tanong ni sir. Okay? So, any questions? Any questions? Isang tanong, isang sagot siguro to si Sir Nestor. Pagpasok niya sa patient's room, BP. O, yun lang sasabihin niya sa pasyente. Tapos BP na agad. BP. Ganun na. Oh, yes daw. Oh, totoo pala. Okay, if there are no questions, let's have a 5-minute break and then we will continue. Okay? So 5-minute break muna tayo, then patuloy tayo. Okay, let's continue. Ang next topic natin is loss, grief, and crisis. Okay? So loss. Loss can be the absence of something desired, no? Something na gusto mo, nawala. It could be a person, place, a thing, or even limbs, di ba? Yung mga amputees, they also experience loss. So, there are different types of loss. Meron tayong actual loss. Actual loss is something that can be verified or identified by another person. For example, if you know someone who has lost a spouse, a family member, no? Tapos nakita mo nalulungkot siya, ibig sabihin, you can identify that person has lost something. Next, perceive. Perceive loss, no? It cannot be verified by others. Only one person experiences it, no? The loss, no, yung person mismo na nawalan. For example, itong mga may hoarding behaviors, di ba? Itong mga hoarding behaviors. When you start removing their hoarded things, no, nalulungkot sila. Pero from an external perspective, ang tingin natin sa kanila, di ba, bakit sila malulungkot na basura naman yan? That is what we call as perceived loss because they are the only one who can experience it. No? Even loss of a favorite car, pwede din. Next, anticipatory loss. Anticipatory loss is a type of loss that has occurred before the actual loss. No, ibig sabihin, for example, you have a family member with a terminal disease, stage 4 cancer, ganyan. So you would know that this family member will soon die. Alam mo. So, anticipatory loss yan kasi alam mo na mawawala siya eventually. So, nag-grieve ka na even if hindi pa siya nawala. So, what is our nursing intervention if there is loss? Of course, communication. Ito talaga yung best. Allow the expression and feelings. No? Allow expression and feelings of both the client and the significant others. Next, fulfill informed choice. Ibig sabihin, if they have advanced directives, we have to honor it. We have to honor it. Kung sasabihin ng mga SO na wag gagawin, hindi natin pwedeng susundin sila. We have to honor the patient. No? Kasi, pag hindi natin sinusunod si patient, yung mga advanced directive niyan, then, na binabangga natin yung ethical principle na autonomy. Next, facilitate the grief process. Yung tinatawag nating DABDA, and the stages of it. We facilitate it with the SOs, etc. And also other nurses. For example, meron na mga long stay na patient. Kaibigan niya na lahat ng mga nurse, lahat ng mga doktor doon. Tapos pag namatay, then pati yung mga nurses, yung mga doktor, they start to feel loss or grief kasi kilala na nila. Also, follow your transcultural nursing. We have to consider the client's culture, okay, the religion, on how they practice loss and grief, and also self-awareness. Huwag nang tatandaan natin that we have to perform introspection. Introspection. Now, importante ito siya because without self-awareness, if there is loss, without performing introspection, nagkakaroon tayo ng compassion fatigue. Ibig sabihin, because nakita mo na to 1,000 times, namatayan ka na 1,000 times, parang wala na lang sa'yo. You are jaded. So, to prevent that, they say na kailangan mo mag-practice ng self-awareness or introspection. How do I feel about the situation? Ano ba nangyari? Etc. Okay? Now, when somebody loses something, they start to feel grief. Grieve. Nag-grieve sila. Grief is a subjective emotion in response to loss. Meron daw tayong stages of grief by Kubler-Ross. I'm sure familiar na kayo dito. DABDA. Denial, anger, okay, bargaining, depression, and eventually acceptance. no? Tatandaan natin yung stages of grief, kahit na dabda yung nakasulat dyan, hindi lahat ng patient, no, will follow the exact same stages or the exact same process of grief. Hindi sila magiging denial first. And then, magbabargaining, and then magiging anger, wala. No? Hindi ganun dapat. Everyone experiences grief at different stages. Basta ang tatandaan lang natin, okay na ba? No, ang tatandaan lang natin is that the difference the different stages of grief, no, or the patient undergoes these stages, albeit not in perfect order. Some patients become anger first, no, nagagalit sila first. Ang ibang patient nagbabargain first. Some patients accept it first, and then magiging silang depressive, denial, ganyan. So paiba-iba. Pero ang importante is each of them, no, almost all patient experiences this at some point or another. Or individuals who has experienced loss will experience this some point of or another. Now, there are different types of grief. Normal grief is usually it can last from month to year, no, from month to year. Anticipated grief naman, no, occurs before the loss. Disenfranchised grief, ano ibig sabihin nito? Disenfranchised grief, ito yung hindi mo na-express yung grief mo. No? You cannot openly experience this grief. Bakit? No? It could be because of societal norms, no? It could be because of a personal reason, and so you cannot experience this grief. Hindi mo pa rin ma-express. Now, this can be dangerous because if you cannot express grief properly, it can be turned inward. No? It is turned inward. And once it is turned inward, it becomes, no, self-harm. Kasi hindi mo siya na-express, you turn it inwardly, so you start harming yourself. Dysfunctional grief naman, no, kapag ang dysfunctional grief is a normal grief, however, naging na siyang dysfunctional kasi yung coping mechanism mo nawala. Wala ka ng coping mechanism. Now, there is lack of progression to cope. Okay? Patients who have dysfunctional grief, from the name itself, become dysfunctional. When you say dysfunctional kasi, in psychology, it means inability to work, no? Inability to maintain relationships, to take care of oneself, ganyan. So nawawala na yung kanilang functionality. Hindi na sila nakakakain, hindi na nagtatrabaho, pumupunta ng eskwelahan, naliligo. That is what you call dysfunctional grief. And because they cannot cope anymore, this leads to crisis. No? Crisis. And delikado yan once it goes to crisis. Okay? So ano nangyayari kapag crisis na tayo? So next slide, 1, 2, 3. Yan. So what is crisis? Crisis is a temporary state of emotional disorganization. Okay? You are disorganized. You can no longer go to your classes. You are no longer working. You are just in a crisis stage. Ang crisis is usually 4 to 6 weeks. Now, this is usually due to dysfunctional or prolonged grief. Nawala yung coping mechanism or dysfunctional na yung grief mo, ganyan. Now, there are different types of crises that can arise in different situations. Meron tayong maturational, situational, adventitious. Maturational crisis, usually this is a crisis that is expected or predictable. Commonly related to siya to developmental stages. No, developmental stages. An example of maturational grief, crisis would be, no, being hired in a new job. Ganyan, bagong trabaho. Diba? For a certain period, hindi mo alam nangyayari, medyo dysfunctional ka. No? There is a loss because you have already lost a certain portion of your life. Hindi ka na college, hindi ka na bata, may trabaho ka na. But after 4 to 6 weeks, no, nag-a-adjust ka na. So it is usually developmental. Aside from that, no, first time na magkaroon ng anak, di ba? So you are no longer um, a woman, no? You're a mother, di ba? Nanay ka na. So there is a loss and there is something, no? A crisis that has changed your developmental. No, first time nagpakasal, ganyan. So this one, no, developmental is maturational is usually related to a developmental stage. Okay? Next, situational or tinatawag din nilang accidental. Now, this one is unanticipated. Hindi mo nababantayan. Now, these are life events that can upset the psychological equilibrium. For example, a divorce, no? Hindi mo nabantayan, iniwanan ka na, no? Severe illness, diagnose ka pala ng cancer, no? Or natanggal ka sa trabaho, loss of job, no? Or loss of a loved one. So something that is unanticipated, hindi mo nababantayan. Ang adventitious naman or tinatawag nilang social crisis, this is not commonly part of everyday life. This is usually related to natural disasters. Nasira yung bahay dahil nabaon ng tsunami, ganyan. Or violent crimes, you were raped while going to work. So that is adventitious, no? That is not part of everyday life. So these types of situations can cause crisis to a person, as well as grief can cause crisis to a person. So to treat this one, no, kapag meron ng disorganization si patient, nasa crisis na siya, we have to treat it immediately, no, as soon as possible, para hindi siya maging disorganized sa kanyang buhay. We have to treat it immediate, offer support, and direct response. And direct response. Ganyan. Next, dapat may goal si patient. Tapos, yung goal niya should be realistic. Here and now. No? It should address the problem. For example, no, first time sa trabaho. Okay? Commonly, ang ginagawa ng mga companies dyan is merong training. No? Training in people with the first time working in a company, in a hospital, is a form of crisis intervention para hindi sila disorganized, para alam nila kung anong ginagawa nila. Next, increase the client's awareness of feelings. And lastly, no, hanap ng magandang coping skills. No? The coping skills should be healthy, hindi self-destructive. Okay, so that's for your crisis. Any questions? No questions? Okay, next topic tayo. Our next topic is about violence, abuse, and suicide. Violence, abuse, and suicide. So itong violence and abuse ko, no, na ano ko na to siya, sum up ko na to siya for both adult, elderly, and sexual. Okay, so I will just mention certain mga ibang nursing interventions na makikita lang dito sa type of abuse na to if necessary. Pero na-lump sum ko na to siya. So what is a characteristic of an abusive family? One, there is intergeneration. It means that it is been happening throughout generations, no? Yung bata in-abuse ng kanyang papa, no? Grow up to abuse his own child, grew up to abuse his own child, etc. Next, there is someone abusing alcohol or drugs in the house. Next, they are socially isolated. Now, when you say socially isolated, they are not in good terms with their neighbors, no? Or hindi sila nakikipaghalubilo sa kanilang mga neighbor, etc. And also, there is an abuse of power. So when you say abuse of power, there is someone that is usually abusing power there. Commonly, no, this usually pertains to money. No? Kung sino yung primary earner, okay, syempre, siya yung may pera, siya usually yung nakakaabuso. Okay? So there is an abuse of power. So what is the characteristic of an abuser? Ang ating acronym dyan is pinch, nangungurot daw sila. Okay? Pinch, they treat their victims as property. Not as people, but as property. Next, I. They have impaired self-esteem. That's why they cope. The way they cope is they hurt others. Next, N. They have a narcissistic trait. C. No, they are codependent. H. There's history of abuse. History of child abuse. So they have been abused before. And because yan yung natutunan nila growing up, they abused yung mga loved ones naman nila. So, for the victim, what is the characteristic of a victim? TBD. They feel trapped. Hindi sila nakaka-escape. B. They blame themselves. And because they blame themselves, that is why merong codependence na nangyayari. That's why nagkakaroon ng codependent. It's because they blame themselves. They see themselves as part of the issue, not just the abuser alone. And lastly, D. They are depressed. Malungkot. Okay? So how do we intervene? Pag nalaman natin na may abuse na nangyari. First, we will report. Kanino mo ire-report? Sige, kanino natin ire-report? Should we report it to the charge nurse? If there is suspected abuse, should we report it to the charge nurse? Should you report it to the head nurse? What about the doctor? Should we report it to the doctor? Lahat ng answer doon is no. Because we have to report it sa proper authority. Very good, sa ating mga proper authority. Okay? So when you say proper authority, it means kung elder abuse yan, then elder protective services. Kung adult abuse yan, adult protective services. Kung child abuse naman, child protective services. So hindi ka na magre-report sa yung sa yung charge nurse, head nurse, manager nurse. Huwag mo na din i-report kay doc. Hindi na necessary. Okay? Diretso ka na sa tamang otoridad na magti-take care sa kanila. Okay? So bakit kaya? Why should we not involve the other people? Kung meron suspected abuse, bakit diretso na tayo magre-report? Ano kayang rason natin dyan? Any idea? No idea? Okay, so the reason kung bakit hindi na tayo magre-report, safety para hindi na ma-prolong, yes, Kasi bias, correct. Tama yung mga sinabi nyo. Para hindi na ma-prolong kasi pag nagre-report ka to a higher chain of command, di ba, bureaucracy yan. Ni-report mo kay ganito, si ganito magre-report kay ganyan. Si ganyan magre-report kay dito, tapos si dito magre-report naman sa dyan. So, ano nangyari sa pasyente? Wala na nangyari sa pasyente kasi report hanggang paakyat. And yes, correct, bias. For example, napansin mo may abuse, may bruises si patient sa kanyang leeg, sa kanyang batok. Ni-report mo kay doc. Sabi mo, doc, I think abuse tong patient na to. Pagtingin ni doc, hindi naman to abuse. So ano nangyari kay patient? Again, walang nangyari kay patient. So that's why when there is a suspected abuse, you report immediately to the proper authority. Sometimes sa mga ER, meron din tong code, Tawag nila is abuse code. So pag nalaman nila na suspected abuse si patient, diretso na. Meron na silang protocol anong gagawin. So hindi na kailangan mag-report. And lastly, nurses are considered as obligated reporters. Okay? So ibig sabihin, pag nakita ni nurse na may possible abuse, suspected abuse, kailangan niya talaga mag-report. If the nurse fails to report, negligent siya. Okay, next. After that, you assess for evidences. Assess for evidences. For sexual abuse, ito yung mga importanteng tatanungin. Okay, for sex abuse, tatanungin natin if the patient has showered, no? Showered, ano pa? Douched or bathed. Okay? Tatanungin natin, naligo ka na ba? Nag-shower ka na ba? Or nag-douche ka ba? Because all of this action can compromise potential evidence. Additionally, now for patients who have been sexually abused, ang kanilang unconscious action is to wash themselves, no? Because parang ano siya, figuratively parang nililinisan nila yung katawan nila, no, of the thing that happened, and literally nililinisan talaga yung katawan nila. So para walang evidence na nangyari. So that's why it's very important to ask if the patient has shower, douche, or bath. Next, sasabihin din natin si patient that a pelvic exam will usually be indicated. No? Inform natin si patient na may pelvic examination. So pelvic examination is to identify any injuries or to collect further, no, evidences if needed be. Next, complete the assessment. No? Dapat yung pag nag-assess tayo, we should be in a, no, private room. No? It should be honoring the patient's privacy and confidentiality. Ganyan. Part of the assessment, sa assessment kapag sexual abuse, tinatanong din natin if kailan yung last menstrual period. Okay, kailan yung LMP and ano yung birth control na ginagamit. Because, no, prophylactic medications can be given to this patient. No? Kasi meron silang risk for unwanted pregnancy. So, pwede silang mabigyan ng prophylactic medications. Aside from prophylactic medications to prevent pregnancy, pwede din sila bigyan ng prophylactic medications to prevent STIs. No? Pwede din sila bigyan ng gamot to prevent STIs. Okay, next. No? When we complete our assessment, we have to do it head to toe, di ba? Dapat dinodocument natin lahat. No? Dapat dinodocument natin lahat. Lastly, no, after na-document natin lahat, itong mga self-protective behavior, safety plan, counseling, this will all be done once the patient has been properly assessed. No? Self-protective behavior means proper problem-solving skills. In case na mangyari ulit, kung ano nangyari, sino yung mga tatawagan ni patients? Saan siya pupunta? Ano yung safety plan niya? No? What would be the fast escape if it happens again? No? If violence returned, you can offer them hotlines for safe houses, shelters, etc. We can also recommend them for therapy and counseling if needed be. And lastly, do not forget to document everything. Okay, question. Can we interview an abused client? Pwede ba tayo mag-interview? Correct answer is no. No? Hindi tayo pwede mag-interview. We cannot ask what happened, where it happened, who did it, etc. Because we are not trained for that. We should not interview. If the patient wants to share, go ahead. The patient can share. Pwede kang makinig. No? Pero wag mo siyang baliwalain. Wag mo sabihin, we cannot talk about that right now. Just let the patient share. But you should not interview the patient. Yes, correct. No? Forensic nurse lang ang pwedeng mag-interview ng mga abused patients. Okay? Any questions with this one? Abuse sign language. Yan ba yung parang for the lack of better words, so parang may mga gang sign sila sa'yo na sinasabi nila na abuse sila. Diba parang ganun? Ganun sila. Oh. Yeah, that's correct. Uso sa US. So kung may nagaganon-ganon sa kanila, no, baka bloods sila. So ikaw din. Ganun ka rin, yeah, bloods. Para malaman nila kagang kayo. Okay, joke. No? Itong abuse sign language, this is a sign para makita daw. No, it's a way of calling help. Okay? So any questions? Any questions before we proceed? No questions? Okay, let's talk about child abuse. Okay? Now, so child abuse, excuse me. So, how do we determine if the child is suspected child abuse? So, meron tayong shades. Natatandaan mo shades. Di ba yung mga inaabuso, nagsusuot sila ng malalaking shades para matago yung kanilang mga black eye. So, shades. S is for serious injury. Sorry. Serious injury of various healing stages. Okay? Stages, sorry. So, ibig sabihin, meron siyang mga pasa-pasa, pero iba-iba yung healing stages. For example, ito fresh. No, may fresh siya dito, may maghihil na or naghihilom na. So, serious injury of various healing stages. Another S would be strange injury. No? Strange injury. So, in law enforcement, meron silang tinatawag na defensive wounds. Yung mga wounds nakikita dito, no? Tawag daw nila defensive wounds. So, if you see a child na ang daming pasa, no, sa kanyang kamay, baka he's trying to defend himself. Ganyan, tapos binubugbog siya. So, strange injury or mga injury na hindi commonly nakikita doon. For example, there is, no, bruises sa kanyang batok, sa kanyang nape. Diba? That is strange. Bakit ka nagkaroon ng bruise sa iyong batok? Yan, next. H. H is for, tawag yan, hair in different length. Hair in different length. So yung length ng buhok nila paiba-iba. May mga mahahaba, yung isa dito, may mga pahak na, no? Natanggalan. Bakit kaya? Why is that a sign of child abuse? Hair is in different length. Hair pulling pwede, no? Sinasabunutan, kaya natatanggalan ng buhok. Ano pa? Ginugunting, yes. No? Ginugunting as a sign of punishment. No? Speaking of gunting, because sometimes children that have been abused, usually ginugupitan sila sa loob ng bahay. No? Ang nagugupit sa kanila, yung parents lang nila. The reason kung bakit hindi sila nagpapakupit, para hindi makalabas ng bahay, no? And also, kasi kung nagpapakupit sila sa mga barbero, sa mga parlor, no, pagtingin ng mga barbero, pagtingin ng mga parlors, ang daming pasa ng ulo, no? So kung makikita 'yun ng mga barber, mga parlor, di mabubuking sila. That's why sila lang nagugupit para matago. So hair in different lengths. Next, A, or unkept hair, no, madumi yung buhok. Next, A is apathy. No, apathy towards pain or apathy in emotion. Normally, ang bata na ina-IV, di ba, umiiyak. But for them, they are apathetic, hindi na sila nasasaktan. D is depression. E is excessive knowledge about sex. No, excessive knowledge about sex. Bakit alam na alam niya itong mga klaseng information na to? Probably because these things were done to him or her. So excessive knowledge about sex or extreme behaviors. No, extreme behavior such as hurting animals. Ganyan. No? Because alam niya na sinisipa siya ng kanyang tatay, sinisipa niya din yung aso. Okay? And lastly, S, self-esteem is low, no? Self-esteem is low. Yan. So again, what is our intervention? Pinaka-best talaga, if you have suspected that these patients are abused, report agad. You have to report it. When you collect evidences, no, it should be done privately. Okay? Privately and honoring the patient's confidentiality. Now, what if nandyan yung parent, no? Paano mo mako-collect yung evidence privately? Now, that's why you report first. That's why yun ang gagawin mo first. Magre-report ka because the appropriate authority will come to that place tapos ise-separate yung dalawa para magawa mo yung iyong trabaho privately na walang gugulo sa'yo. No? Next, your movement should be deliberate. No? When you say deliberate movement, dapat ang movement mo is accurate. No? Slow. Dapat hindi ka lumbering kasi baka ma-startle yung patient, baka matakot siya. Okay? Move slow, move accurate, avoid loud noises. No loud noises. When you communicate to the patient, dapat eye level. No? Eye level and according to developmental stage. No? Is the patient an adolescent, a toddler, school age? So appropriate dapat sa level niya. Next, use appropriate words, no? Most of the time, pag mga bata kasi, no, tapos inaabuso sila, anong sinasabi nila, no? Sinasabi nila na, it's my fault. Nangyari to dahilan ginawa ko to. So that's why, pag mga bata, you tell them na it's not their fault. Don't tell them that it's not bad what they're doing, no? Don't tell them they are bad or responsible what happened. Kasi most ng mga inaabuso na bata, yan ang first nilang go-to narrative. No? Sinasabi nila na nangyari to kasi masama ako na bata. Okay? So don't tell them they are responsible. No? Responsible when na nangyari sa kanila. Next, avoid making assumptions or communicating your emotions. Avoid showing emotions. Okay? Hindi mo pwedeng ipakita na galit ka or no, empathetic ka, na naluluha ka sa mga nangyayari sa bata na to because no, if if your actions are swayed by your emotions, then hindi na unbiased biased na yung documentation mo. So, as much as possible, avoid communicating your emotions. And lastly, document everything accurately and completely. Okay? So, any questions with abuse, violence and abuse? Okay, so kung kasama yung parent, no, hindi ka pwedeng makaka-collect ng evidence privately pag nandyan yung parent. That's why the first thing that you should do is report. Kasi after mo na-report, pupunta yung appropriate authorities and they will separate, no, the possible abuser to the suspected abuse. No, that's why report mo na para ma-separate sila and then you can conduct it privately. Okay, so any questions? No questions? Okay, let's answer the following. A female client, a female client 4 years old brought to the ED by father stating client has painful urinations. Okay, physical assessment shows the hair has noticeable bald patches. So yung buhok niya may mga bald patches. There is missing teeth, upper incisor. There is yellowish contusions around the neck. There is healed abrasion on the right elbow. Fingernails show signs of onychophagia. So onychophagia is yung nail biting. Medical history shows asthma and chronic UTI. Vital signs as follows. Temperature is 38.5, heart rate 120, RR 30, BP 90/60, BMI is on the 5th percentile. No? So pag nasa 5th percentile si patient, they are usually considered, no, underweight. Okay, select, no, the nurse reviews the client assessment, select 4 findings that are of immediate concern. Okay, bold patches. Concern or not concern? Apat lang kailangan natin, ha? Excuse me. So, concern natin yan. Okay, check natin. Next, missing upper incisor. Wala daw siyang ngipin sa taas. Is that a concern? O, tatandaan natin, 4 years old, no? Exfoliation of the teeth is between 5 to 6. Diba? Yung nahuhulog yung ngipin, usually nasa 5 to 6 yan. So, 4 years old, that's not a problem. In fact, common yan siya. No? Nahuhulog na yung DBT. Okay, next. Yellow contusion around the neck. Meron siyang, ano dito? Yes, that's a concern, di ba? That's a strange wound. Bakit nandyan? BMI, 5th percentile, underweight na bata. Yes, concern yan. History of asthma. Not a concern. Pakip niya. Mabilis yung kanyang paghinga. Okay, so isipin natin, 4 years old, nasa emergency department, of course, takot talaga tong bata na to. Tachycardia. Hindi din. Temperature, 38.5. What do you think? Is it a concern now? Temperature niya, meron siyang fever. No? Okay, so isa na lang kailangan natin. Onychophagia, nail biting, is that a concern? Okay, not a concern. History of UTI. So, tatandaan mo, meron siyang UTI ngayon and meron siyang chronic UTI, paulit-ulit. O sige, between temperature and the UTIs, anong pipiliin mo? You need only one. Kasi meron na tayong tatlo. I will also pick UTI. Yung paulit-ulit na UTI. Okay? Because pag pinili ko yung UTI, ina-answer niya na rin yung temperature. Okay? So yung UTI niya, it is just not a history. No, meron siyang chronic UTI, paulit-ulit. And ngayon, meron na naman siyang UTI. Diba that's concerning? It's not common for a child to have consistent UTI, paulit-ulit na UTI. It could mean, yes, no, possible sexual abuse. No, possible sexual abuse. So correct. Okay, so the answer is bold patches, yellow contusion, BMI, and history of UTI. Okay, next tayo. Okay. A 28-year-old client has been hospitalized for the past few weeks after being violently raped. Immediately after surgery, the client was alert and oriented. Speech lability noted when talking to male medical professionals. At 1600, reports difficulty sleeping. Hindi daw siya nakakatulog. Usually awakened from nightmares, able to sleep when the room lights are on but admits to have restless, incomplete sleep. States loss of appetite for most days, complaints of nausea and episodes of constipation, reports periods of headaches and dizziness, states having previous multiple sexual partners, complaints of episodes of anxiety, often worsen at night when alone in the room. Vital signs as follows. Temperature is 36, RR 13, pulse rate 100, BP 130/90. The nurse reviews the notes and recognizes that the client has a possible sign or potential sign of rape trauma syndrome based on blank, 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 and blank. 1, 2, 3, 4. So, 4 findings ang kailangan natin. Okay? Labile speech. Could that be a sign of rape trauma syndrome? speech lability, speech lability is that, could that be a sign of rape trauma? No, no? Hindi. At saka medyo general to. Does it mean na labile yung speech mo or talkative ka, na-rape ka na? Okay, next. Nightmares. Hindi daw siya makatulog kasi lagi siyang nagigising sa kanyang mga nightmares. Would that be a sign of rape trauma? Yes. No? Kasi the nightmares could be the rape. No? Yung na-rape siya, yun yung nightmares. Next, hypertension. Would that be a sign of rape trauma syndrome? No. No, we have to take in consideration, hindi na siya natutulog. If you are constantly under stress, tataas talaga yung alta pressure mo. Okay, next, fears and phobias. Ibig sabihin, meron na siyang takot, no? Saan siya takot? When alone in the room. Pag siya lang mag-isa. Oh, yes. Sexual promiscuity. Sinabi niya na, I had previous multiple sexual partners. Could that be a sign of rape trauma? Of course not. No? Hindi ibig sabihin na promiscuous ka or you had multiple sexual partners, meron kang rape trauma syndrome. Anorexia or the loss of appetite. Hindi na daw siya kumakain. Wala nang ganang kumain. Yes. Okay? Because if you're not eating, it is usually because of certain preoccupations. No, preoccupied na yung ulo ni client. Constipation. That a sign? No. Headaches and dizziness. Of course, mahihilo ka, no? Sasakit ang ulo mo kung wala kang tulog. Lalong-lalo na if you sleep with the lights on. Anxiety. Yes. Okay, so the correct answer is 2, 4, 6, and 9. These are symptoms of rape trauma syndrome. Okay, so what is rape trauma syndrome? Rape trauma syndrome is just PTSD. Parehas lang ito ng PTSD. Okay? But instead of post-traumatic, it is talking about a specific trauma. So rape trauma syndrome is one of it. War trauma syndrome, so ibig sabihin galing ng gera, tapos traumatized na siya doon, etc. Okay? So next topic natin would be suicide. Labile speech, madaldal. No, madaldal. So si patient na to, hindi siya masyadong madaldal, pero pag male daw yung professional, madaldal na siya. Okay? That's what you call labile speech. Okay? So, before we discuss suicide, no, may tanong ako sa inyo, kumain na ba kayo? Okay lang po ba na mag-dinner break tayo 20 minutes and then we continue with suicide? Kasi baka, no, baka magsusuicide na tayo kung hindi na tayo kakain. Okay, sige. Dinner break muna tayo 20 minutes and then let's go back. Para hindi kayo mag-suicide, ha? Ang topic pa naman natin, suicide. Eh, grabe na yung aral namin, sir. Magpapakamatay na ako. Okay, sige. I'll see you back after 20 minutes. Okay? Okay? Tapos na ba kayong kumain? Can we continue? Sige, let's continue. So, ang topic natin is suicide. There are risk factors to suicide. Yung ating um, risk factors for suicide, tinatawag natin as SAD persons. No? Acronym po siya, SAD persons. Excuse me. S is for sex. Okay? Yung hindi nakaka-sex, malamang nagsusuicide yun. Hindi. Ano yung sex? Ano yung sinong sex ang mostly na nagsusuicide? Males or females? Sino yung common na nagsusuicide? Males or females? It's your males, no? Males are common na nagsusuicide as compared to females. Okay? So, females, usually ideation sila. Whereas males is no, the act of suicide. Okay? Next. Age. Ano yung age daw? Less than 18 at greater than 45. Okay? D is for depression. They are diagnosed with depression or they are taking antidepressants. If they are taking antidepressants, yung mga MAUI, SSRI, TCA, etc. Next, previous attempt. So, if they had a previous attempt of suicide, the succeeding attempt, no, tumataas yung success rate. Okay? E is for ethanol abuse. And not just any ethanol abuse, no? Also, drug abuse din. No? Drug abuse. R, no? Is rational thinking is impaired. Hindi na sila nag-iisip. S is for social support, impaired. Ibig sabihin, walang mga kaibigan, no? Walang pamilya, sila lang mag-isa sa bahay. Ganyan. Wala silang social support. O is organized plan. So, meron na silang plano on how to commit suicide. N is no spouse. Walang partner or no, recently divorced or recently died. No? Namatay or nag-divorce. S is for sick, may sakit. Usually yung mga chronic condition, no? Or mga neurodegenerative condition. Neurodegenerative. Yan. Yan daw yung SAD persons natin. So what is our intervention? Yes, pwede din, naging spouse, no? No spouse or naging spouse, recently divorced spouse, recently dead, ganun. So, in general, wala silang partner sa buhay. Okay? Pwede din na naging spouse or recently divorced or dead. Yan. Okay? So what is our nursing intervention? Assess and monitor for plans of suicide. So babantayan natin, is the patient hoarding means of suicide? When you say hoarding means, no, these patients are collecting ways, no, organizing ways to kill themselves. No? Hindi siya gumagamit ng baril, bigla lang bumili ng baril. No, yan, keeping a gun. No? Yung mga kutsilyo sa kusina nawawala. Nakita mo sa nasa room na pala ng patient. Ganyan. So they are organizing means or hoarding means for suicide. Next, they are giving away personal things. No? Giving away personal things is their way of saying goodbye. No? Nagpapaalam na, nagpapasalamat na sa inyo. No? When they start giving away their personal things. Next, there is a sudden change in behavior. No? A sudden negative or a sudden positive change in behavior. So ano ibig sabihin sudden negative or sudden positive? Ibig sabihin, no, kung depressed sila, anergia, wala silang energy, And then suddenly bigla lang, no, gising na, masaya na, tumatawa na, etc. There is a sudden positive change, delikado yan. Or, no, yung opposite naman, they're happy, they're okay, no, they're talking to people, and then suddenly, nagkukulong na sa loob ng kwarto, hindi na lalabas. A sudden negative change in behavior. So, sudden positive or sudden negative, we have to watch out for that. Okay, next, safety, security, and supervision. No, safety, security, and supervision. Now, ang patient na at suicide risk, usually they are under frequent unscheduled visits. No, frequent unscheduled visits. Sometimes, meron silang 24/7 monitoring. No? Naka-monitor sila 24/7. Tapos, near nurse station. Okay, safe environment. Now, when we talk about safe environment, no, we have to remove any lethal object inside their environment. Are there any excess wires? No? Excess cloth? Meron bang mga ceramic? Meron bang mga glass na pwede nilang basagin? Can use to kill themselves. So you have to remove these lethal, potentially lethal objects. Okay. And then lastly, therapy. No, they have to sign a contract. So ano ibig sabihin ng contract? No? It could be a suicide contract or it could be a yung tawag niyan um, involuntary um, kalimutan ko na yung term, involuntary admission. Ayun. Involuntary admission. Yan. So ano tong involuntary admission? If doctors, no, usually team to sila, doctors, no, people from the legal world, etc. If they deem you to be, tawag yan, they deem you to be suicide risk, they can admit you without consent, no, without your consent. They call it as involuntary admission. Now, kapag napunta si patient sa involuntary admission, they have 12 hours to draft a contract, and this contract will tell the patient, no, kung bakit kailangan siyang i-admit. Okay? The patient can show this one to his or her lawyer, no, that's okay. Pero usually, once this is approved, no, by a judge, kahit na may lawyer pa yan, the patient will be admitted against his will. Kasi proven na meron siyang suicidal tendency or danger to himself siya. Usually, ang involuntary admission, that is 24 to 48 hours. Admitted ka for 24 to 48 hours. No? And you are monitored 24/7. No? So may nakatutok sa'yo, tinitignan ka. Sometimes, no, it gets more invasive because in a involuntary admission, tinatanggalan sila ng damit. Okay? Naka-ano lang sila. Naka um, shorts, ganyan, naka-t-shirt, and naka-shorts lang sila mostly. But the patient can deny this one, ha? Pwede silang mag-deny for intrusiveness. Okay? Pero normally, yan yung ginagawa. Okay, so 24 to 48 hours monitored sila. After 24 to 48 hours, they are reassessed, no? Tapos kung danger pa rin sila, ikikip na naman sila doon sa admission nila. Again, it needs 12 hours to draft a contract so the patient can see, no, kung bakit kailangan siyang i-admit. 24 to 48 hours yung admission niya, no, for involuntary admissions. In an involuntary admission, people can still visit the patient. Pero ang tatandaan natin, yung mga tao na mag-visit kay patient are screened. Hindi basta-basta kung sino lang yung pwedeng magbisita sa patient. They should be screened, no, for safety purposes. Okay? So, any questions? Any questions? May questions ba tayo? No questions? Okay, let's continue. Let's answer the following. A client is being interviewed by the nurse after repeated ideations of suicide. For each facet of the biopsychosocial model, click the potential risk factors that are a concern for suicide risks. Each facet may support more than one risk factors. Okay. Oh, sorry. For the biological, no, 30 years old. Is that a risk for suicide? 30 years old? No. No, mali. Kasi dapat less than 18, greater than 45. Okay, next. Male. Yes, that is a risk for suicide. Diagnosed with dyslipidemia. Not a risk factor for suicide. Prescribed with atorvastatin. No din, mali din to. Okay, next. For the social, employed as a hospital staff. Does that increase your risk for suicide? No. No? Recently divorced. Yes. Okay. Failed the NCLEX exam. O yung mga nag-yes, tignan mo, mga lalaki usually nag-yes dyan. Which proves the point that suicide is common among males. Hindi, joke lang. So the correct answer is no. No? Hindi ibig sabihin, nabagsak mo yung exam, eh, magpapakamatay ka na. Grabe naman. No? Grabe naman. Meron na namang next chance, di ba? Hindi naman mawawala yan. As long as no, may paraan, kakayanin, di ba? So, mali siya. Okay, next. Muntik na ako mag-yes. O, mga lalaki kasi nag-yes dyan. No, prone to suicide ang mga lalaki. Next, no close family ties. This factor, yes, kasi socially, tawag yan, impaired. O for the psychological, trichotillomania, nagbubunot ng buhok. Risk factor na ba yan for suicide? No. No, hindi ibig sabihin nagbubunot-bunot ka ng buhok. Meron ka ng risk factor to suicide. History of fentanyl abuse. Yes. No? Takes recreational marijuana. O, nasa US tayo. Nasa US tayo, recreational marijuana. So, recreational marijuana is considered not an abused drug, di ba? Nakasulat naman sa recreational. Okay, so hindi kasali. Next, prior arrest due to aggravated result. May binugbog siya. No? That is yes. Kasi poor impulse control, no? Pag galit siya, bigla lang may nasasaktan. So, pag malungkot siya, pwede niyang patayin sarili niya. So, poor impulse control. Hindi niya nakokontrol yung emotions niya mabuti. Okay, next. A nurse is interviewing the record of clients to be seen during the day. The nurse determines that which client is the highest risk for suicide. Number 1, a 45-year-old, recently divorced, chronic depression. Number 2, a 25-year-old, housewife, widow, and has 1 to 2-year-old son and a 3-year-old son, stepdaughter who is ruminating. Ang dami naman ito. Number 3, an admitted 18-year-old male, alcohol and cocaine abusing youth was dumped by her girlfriend 5 years ago. Or number 4, a single parent who failed the civil service exam and whose 6 children are on scholarship in graduate and medical school. Okay, sino dyan yung mataas ang risk? Isa lang pipiliin natin. Okay. So, maraming pumili ng number 1. No? Si 2 and 4, mali na agad. Pero si number 3, bakit hindi nyo pinili? No? The correct answer is number 3. Bakit si number 3? Dahil sa word na to, no? Unadmitted. Ibig sabihin, nilagay na siya sa hospital mismo. So this patient can no longer function outside, the medical facility. Inadmit na talaga siya. Aside from being admitted in a hospital, 18 years old, check. Alcohol plus cocaine. So dalawang forms of abuse. And also dump. So wala siyang partner. So number 3 has a more risk, more risk for suicide. Okay? So any questions? No questions? Okay. Let's talk about the neurobiochemical basis of psychiatric disorders. Okay, so on your left, these are common neurotransmitters, and on our right, these are your common disorders associated to these neurotransmitters. DANGs cause SAMAD. D is for dopamine. Okay, N is acetylcholine. N is norepinephrine. G, GABA. Okay, S, serotonin. Yan. Okay? So ano daw yung kinokos niya? S is for ano yung common psychological disorder tied to dopamine? Schizophrenia, correct. Now, too much dopamine causes schizophrenia. Okay? Pag sobrang baba naman, Parkinson's. Next, acetylcholine causes Alzheimer's. Pag sobrang baba, it causes Alzheimer's. Too much norepinephrine pala, causes mania. Pag sobrang baba naman, depression. GABA. Pag sobrang baba ng ating GABA, anxiety yung nararamdaman natin. And lastly, serotonin. Kapag sobrang baba ng serotonin, depression. Ayan. So this is an easy way to understand the neurobiochemical basis of psychiatric disorders. So therefore, yung mga medications natin is just to correct these neurotransmitters. No? That's why yung antipsychotic, di ba? Anong ginagawa ng gamot na yun? It decreases dopamine. Yan. Yung ating antidepressants, it maintains a balance between your norepinephrine and serotonin. Ganon. So, it depend our medication is usually trying to balance these neurotransmitters out. Okay? So, any questions with this one? Any questions with mga neurobiochemical basis of psychiatric disorder? Yan. So, ito yung pinaka mabilis na way na ma-understand natin. Okay, sige, let's continue with our first psych disorder, ADHD and autism. Okay, ADHD and autism. ADHD, now let's start with ADHD. ADHD usually starts before 7 years old. Bakit before 7? Bakit nila nakikita before 7? Because at 7 to 11 years old, tinatawag natin yan as school age. And during school age, yung mga bata during school age, they love to follow rules. No? They love to follow rules. A child who has ADHD, pag tungtong nila ng 7 years old, pag tungtong nila ng school age, hindi sila nakaka-keep up sa rules. No? Hindi sila nakaka-keep up na umupo dyan, huwag sasagot, dapat magre-raise ng hand. Okay, that's why napapansin na meron silang ADHD pag less than 7 years old. Signs and symptoms. Meron kang inattentiveness, overactive, and impulsive. Hindi nakikinig, galaw ng galaw, and also, they don't think of their action, they just do it. They just do what they feel. Okay? Aside from that, other signs and symptoms, they fidget. Nagfi-fidget sila sa kanilang mga kamay. Ganyan. They interrupt classes or even people pag nagsasalita. So what is our nursing diagnosis for this one? They are at risk for injury. no? Because they self-indulge in physical danger. Hindi kasi nila naiisip yung consequences ng action nila. Aakyat sa table, no? Aakyat sa mga cabinet, tapos bigla lang mahuhulog. Medications for ADHD, no? Meron tayong dalawa, Ritalin and Adderall. Okay, so let's discuss what Ritalin and Adderall does to a patient with ADHD. Okay, these two medications, Ritalin and Adderall, both of them are stimulants. No, stimulants, nakakagising, tulad ng kape. However, when you give Ritalin or Adderall to a patient with ADHD, no, meron siyang paradoxical effect. Instead of, no, stimulating the child more, nagiging siyang calm. No, they become calm. And because they are calm, they can work properly. No, hindi na sila overstimulated. Okay? So, anong difference ng Ritalin sa Adderall? Where ang Ritalin natin, no, it works faster but mabilis siyang nawawala sa katawan, no? It works faster but it, no, goes away significantly. Mabilis din siya nawawala. Ang Adderall naman, no, it lasts longer in the body. No? So, mabagal yung effect niya pero mas matagal siya sa ating katawan. Okay? But we have to understand, no, Ritalin and Adderall, they are still stimulants. No? Mga gamot na to are still stimulants. Ibig sabihin, meron pa rin siyang stimulating effect. Okay? So, it can affect growth of the child. No? Side effects niya, growth is stunted. Usually, hindi masyado sila tumataas. No? The height is affected. Bakit? No? Because being a stimulant, no, yung patients na umiinom ng Ritalin or Adderall, nawawalaan ng gana kumain. They don't wanna eat. So that's why hindi tumataas yung mga bata na to. At the same time, na hindi kumakain, hindi din natutulog. Na um, nawawala yung sensation na inaantok sila. Okay, so that's why stunted talaga yung growth nila. No? Okay, next. What is our nursing interventions here? No? Finger food would be the best. No? Dapat finger food. Pero yung finger food natin, hindi lang basta-basta. It should be healthy. No? Huwag lang puro hotdog. Pwede naman tayo mga fish sticks. Mga ganyan. It should be healthy and it should be high calorie. Usually, ang common example na ginagamit nila sa NCLEX would be your peanut butter sandwiches. No? Kasi peanut butter, high protein, bread, may carbs na, ganyan. Next, decrease caffeine in their food. So, wag nang uminom ng mga colas or other caffeinated drinks because they are already stimulated. Also, maintain safety and, no, structured activities. Okay? When it comes to giving rules, dapat simple, no? Simple but firm rules. Okay? Simple but firm rules. Okay? So ano tong ADHD reward system? No, ang mga patients natin na may ADHD, hindi enough sa kanya yung typical na reward system. No, for example, sinabihan mo yung bata na, no, maglinisin yung kanyang kwarto. Ganyan. Okay? Sa normal na bata, no, after nilinis lahat ng kwarto, no, so lahat ng mga unan niya, na-arrange niya na, yung mga kama, na-arrange niya na, etc. Lahat ng mga laruan, nilagay niya sa hamper, etc. No, after lahat yun, pwede siyang bigyan ng reward. Okay lang yun. For someone who has ADHD, hindi yun pwede. You cannot give a reward, no, after a long build up. So anong ibig sabihin yan? For every action na positive, reward dapat agad. Okay, for example, no, ang patient natin may ADHD tapos sinabihan natin linisin yung kwarto. Okay? So inarrange niya yung pillow, reward agad. Okay? Na-arrange niya yung kumot, reward na naman. Yung mga toys na lagay sa hamper, reward na naman. Ganyan sila dapat. Hindi sila pwede after a long build up. Kasi hindi tumatalab. Okay? So the reward should be mild. Okay? And mild. The reward should be significant and it should be frequent. Parang treat sa pets. Oo, parang gano'n. Parang gano'n talaga. So, everything na may nagawa sila, reward agad para hindi makakalimutan yung action. Okay? Yan yung tinatawag nating ADHD reward system. Okay? O, next tayo, autism naman. So, sa mga usually, ang ADHD, yung kanilang mga gamot is hanggang childhood lang yan. After, tawag yan, after adolescence, no, nagbabalance out na yung mga chemicals sa kanilang katawan, or eventually nagmamature yung kanilang brain, hindi na sila nagkakaroon ng adult onset na ADHD. Okay? Ang ADHD usually, sa mga bata, yan. If they are still impulsive, overactive, inattentive, tapos adult na sila, mania ang tawag natin doon. Okay, so hindi lifetime yung gamot nila. No, hindi lifetime. Okay? So, autism na tayo. So, in autism, this is usually seen before 3 years old. Okay? Ang nakikita nila dito, no, pagkabata pa lang, the patient here, the child here is, no, meron siyang, tawag yan, preference object. No, pag sinabi mong preference object, focus siya to a certain object. Okay? And ano itong mga object na kanyang fino-focus on? Usually, these objects are spinning, paikot-ikot, no? Shiny, ganyan. That's why a child with autism, usually nababantayan nila na laging nakatingin sa ceiling fan, sa electric fan, ganyan. No? Always paikot-ikot kasi gusto nila yon. Okay? Aside from that, they can also show signs and symptoms of impaired social skills. No, hindi marunong makipag-usap or excuse me, there is little to no eye contact. Little to no eye contact. Hindi niya kayang mag-maintain ng eye contact sa kanyang kausap. No, aside from that, they also have RRBs, repetitive restrictive behaviors. So ano tong RRB na to? These are any behaviors that are repetitive and that is resistant to change. For example, no? Meron silang head banging. Yan, a common RRB. Parang ritual, no? Parang ritual pero paulit-ulit nilang ginagawa and usually there is no meaning to this behavior. It is just repetitive. Okay? So, tulad ng head banging, no? Inuuntog-untog yung ulo, rocking, back and forth, pag ganun-ganyan sila, tapping of the feet, ganyan, basta paulit-ulit. Echolalia is another RRB. No? They repeat the last thing you said. No? They repeat the last thing you said. Echolalia. Pwede din echo, praksha. Kung ano yung ginawa mo na last, susundin nila. Pero paulit-ulit. No? This repetitive restrictive behavior is not only, no, in terms of physical movement, no? Pwede din to when it comes to their clothing, no? Their diet, their entire lifestyle, paulit-ulit. For example, gusto nila yung safeguard lang ang sabon nila. Wala nang iba. Safeguard lang. Kung magbigay ka ng ibang sabon dyan, bigyan mo ng mestiza, galit na yan kasi dapat safeguard lang. Gusto nila yung damit nila, no, ganito lang, no, makulay, ganyan. Kung bigyan mo ng ibang damit, magagalit sila. So, repetitive and restrictive. Paulit-ulit. So, what is our nursing diagnosis for this patient? Impaired social interaction. No, impaired social interaction because they cannot understand jokes, no? They cannot understand sarcasm. Para sa kanila, literal lahat yun. Next, walang medications for autism. Pero ang ating interventions dito is as much as possible, we promote safety. No, we promote safety. For our nursing intervention, consistency dapat tayo. No? Kasi paulit-ulit sila. However, even if we are consistent, dapat limit setting pa rin. For example, kung ang gusto nilang breakfast is hotdog, no? Every breakfast for the rest of their life, hotdog ang kakainin nila. But when you limit setting, you limit it, no? Ang gagawin natin is, siguro for the first month, sige hotdog. After that, no? The last day of that last month, of that month, wala na. No? And then slowly tatanggalin natin. So we have to set limits pa rin. Okay, set limits pa rin. Okay? And next, occupational therapy. So the sooner they have an occupational therapy, the faster na tawag yan, na matitrain sila. Okay? So autism and intellectual delays are not they don't go hand in hand. Ibig sabihin, kung autistic si patient, it doesn't mean may intellectual delay sila. Okay? Hindi ibig sabihin ang autistic merong mental retardation agad. They're different, but they can coexist at the same time. A patient who is autistic can also have intellectual disability or intellectual delays. Okay? So any questions with autism? Gluten-free food relation to ADHD and autism. Okay, so wala pa akong nakitang proven studies that there are certain food that can cause ADHD or autism. However, the most common reason for ADHD and autism would be genetics, ibig sabihin, nasa bloodline, okay, or mga um, maternal problems. For example, matanda na, no, tas nabuntis. Okay, matanda na buntis, mga greater than 35 years old. Tumataas daw yung risk for ADHD or autism. So usually, it is genetic, familial in nature. Okay? Gluten-rich food recommended. Okay, so wala pa din akong nabasa when it comes to certain food types, no, for ADHD and autism. Ang sabi sa Saunders, ang recommended should be finger food that is high calorie. Yun yung laging sinasabi, finger food that is high calorie. Best example nila is, tawag yan, peanut butter tapos milk. Peanut butter sandwich with milk. Ganun daw. Okay? So any questions? Before we proceed with no questions. Okay, let's continue. Okay, let's answer the following. Oh, yan. A 9-year-old male with ADHD is seen in the clinic for medication management. At 10:15 or October 15, no, the patient was started in 10 milligrams amphetamine. Okay. Amphetamine is Adderall. No? So Adderall has the same, tawag yan, has the same chemical component as meth or shabu. Magkahawig lang sila. Okay? So, the patient was prescribed with Adderall, no, for ADHD. And the plan is to increase the milligrams per week as tolerated. At November 17, the maintenance dose of the child is now 30 milligrams, no, amphetamine. The patient's weight is stable, and the patient reports feeling better and able to complete tasks. At January 10, no, the family is using a reward as a behavioral management, taking medication first thing each morning. Grades are improving. However, appetite has decreased and troubled sleeping. Flow sheets. Okay, makikita natin dito sa flow sheet niya that mostly everything is normal naman. However, yung kanyang weight bumababa as the months progress. Not only the weight, the BMI as well. And the BMI for the age. Naging na siyang 15th percentile. So bumaba talaga. Okay, so the medication is dextroamphetamine long-acting 30 milligrams, 1 capsule daily, which for finding requires follow-up. Okay, so ano din kailangan ng follow-up? Number 1, behavior management. Does this require follow-up? Yes or no? No. Okay, next. Medication administration. So, ibig sabihin yung dosage, kailangan ba natin i-follow up? Yes, 30 milligrams. Tapos may nakikita na tayong something wrong. School performance. So the grades are improving. Need to follow up ba yan? No, gumaganda naman ang grades. No need to follow up. Appetite. Yes, kasi hindi na kumakain. Sleep. Meron na siyang troubled sleeping. Yes. What about the pulse? 90, 96, 104. Not a problem. What about the blood pressure? Hindi din problema. In normal range din. Paano yung yung timbang niya bumababa? Yan. Okay? So, this patient might have, no, nagkakaroon na siya ng stunting of growth and height. It's because of the medication. Baka sobrang taas na ang 30 milligrams para sa kanya. Okay? Dadagdagan natin. No? Adderall is the most common abused drug in universities, no, sa US. Okay? So yung mga Harvard, Stanford, malakas sila gumamit nito, no? Even for HCPs, healthcare providers, pwede din, no, para laging gising. When is the best time to give the medication? Morning, no? The best time to give the medication morning. Kasi pag nabibigay siya later sa day na, hindi na makakatulog yung pasyente. So the best time would be morning. Ayan. So Adderall, most abused drug in universities. Para aral daw sila ng aral, no? Hindi sila makakatulog. Okay? So any questions? Any questions before we proceed? No question? Okay. Our next topic would be your schizophrenia and antipsychotic medications. Okay, so this topic, medyo mahaba to siya. Okay? And I don't think we can discuss all antipsychotic medication. So siguro we might end on schizophrenia spectrum. No, we'll just see. No, we'll see kung kaya natin tapusin yung entire antipsychotics. Okay, so let's talk about schizophrenia. So before, di ba, marami tayong types of schizophrenia. Meron tayong brief psychotic disorder, delusional disorder, schizophreniform, schizoaffective, etc. Di ba? Ang dami. Now, because of DSM-5, lahat ng mga disorders na yon that are associated to schizophrenia, they put it under the spectrum. No? Nasa spectrum na siya. So when you talk about schizophrenia spectrum disorder, you're actually talking all the associated, no, diseases or all the associated uh, disorders under this one. Okay, so hindi na natin i-discuss ano ang schizophrenia, schizophreniform, brief psychotic, schizoaffective. General na tayo. Schizophrenia spectrum disorder. Okay? So schizophrenia spectrum disorder, there is a chemical imbalance, no? Ano nga yung neurotransmitter na nagkakaproblema dito kapag nagkakaroon tayo? Correct, no? It's your dopamine. Okay? It's your dopamine. Ano nangyayari sa dopamine? Sobrang taas o sobrang baba? Too much dopamine. Very good. There is too much dopamine. That's why the patient starts to develop these symptoms. So what are the signs and symptoms of schizophrenia? We have your positive, negative, and disorganized symptoms. Okay? So positive symptoms, this is the presence of symptoms that normal people don't exhibit. So hindi to siya nakikita sa normal na tao. Common natin mga examples natin under your positive symptoms would be your hallucination, delusion, and illusion. Correct. Hallucination, delusion, and illusion. Okay? A patient who is hallucinating means that they are experiencing a sensory perception without external stimuli. Delusion naman, no, it is a false belief beyond logic. And illusion is a misinterpretation. No? of an external stimuli. Tinatawag natin siyang positive kasi may nadagdag, no? May na-add sa atin. Okay? Next, negative symptoms. Negative symptoms, okay? These are absence of of which that normal people exhibit. So ang normal na tao may nawala sa kanya. For example, no, nakalagay diyan a. For example, a normal person has the energy, no, to perform tasks, to get up in the morning, to eat, to go to work, ganyan. If you have a negative symptom, nagkakaroon ka ng anergia, di ba? Anergia or no energy. O next, a normal person is motivated to fulfill goals, di ba? Gusto mong magpapayat. No, sabi mo yung January magpapapayat ako, September na. So ano na yung plano mo? Okay? You have motivation. But a person, no, who has negative symptoms, meron silang avolition. Nawala na yung will or motivation nila. No motivation. Ayan, so that's why nilagay ko dyan a. Because most negative symptoms starts with letter A. Anergia, avolition, alogia, no, or poor speech, hindi nagsasalita, anhedonia, inability to feel pleasure, ganyan. Pero ang apraxia, okay, you might encounter this one, apraxia is not a negative symptom. Okay, hindi to siya kasali. Kasi apraxia is a neurocognitive disorder. A neurocognitive symptom pala. Okay? Pag nakita mo yung apraxia, wala kang problema with dopamine. Ang problema mo is may nasira talaga mismo na neurons sa iyong utak. Okay? So yan yung ating mga negative symptoms. And last, disorganized symptoms. Ano tong disorganized symptoms? Okay? So disorganized symptoms can be disorganized speech, disorganized behavior, disorganized relationship. So when you hear disorganized, just think of the word abnormal. No? Abnormal. For example, if a patient has disorganized speech, no? They can show the following. Pwede silang magkaroon ng neologism, no? Or the creation of new words. Okay, that is a sign of disorganized speech, abnormal way of talking. Pwede din sila magkaroon ng word salad. This one, wala na talagang connection yung mga words. Okay? Pwede din magkaroon ng clang association. So these are examples of disorganized or abnormal speech. No? Examples of abnormal speech. Okay? Pwede din silang may flight of ideas. Ayan. So madami pa tayong example. Next, disorganized behavior. Anhedonia or no pleasure. No? They cannot feel any pleasure. Next, when you say disorganized behavior, this is an abnormal behavior. For example, no? May nakita ka nagluluhod palakad sa loob ng simbahan. Would you say that that is an abnormal behavior? Yes or no? Naglalakad paluhod sa simbahan, di ba? No. Kasi yung context. Pero what if nakita mo naglalakad paluhod sa road, no? Sa middle of the road. Then it becomes a disorganized behavior. So when you say disorganized behavior, this is strange, no? Abnormal behavior, something that a normal person would not be doing, no? Tulad ng maliligo sa kanal, ano pa, kakain ng dirt, no? Papaglaruan yung tae, magmamasturbate sa public, ganyan. So these are strange or abnormal behavior. Okay, last, disorganized relationship. So when you say disorganized relationship, this patient cannot form any relationship. There is no personal, professional relationship. Ganyan. Wala din siyang relationship sa kanyang sarili. Okay? Ibig sabihin, meron siyang mga disorganized symptoms. Okay, so any questions with this one? Any questions with this one? No questions? Okay, let's talk about the management for patients with schizophrenia. Okay, so the main management, number one talaga, what is to treat them with antipsychotic medications. Tatandaan natin that patients with schizophrenia are functionally psychotic. Ibig sabihin, if they receive the proper medication, no, kaya nilang magtrabaho, walang problema. If you go to US, eventually, pupunta kayo sa US, kaya alam ko makakapasa kayo ng NCLEX, di ba? Mapapansin nyo marami kayong mga workmates doon na may mga schizophrenia, bipolar, ganyan. Because these workmates, no, mga coworkers na yan, as long as they're taking the medication, they can function in society, no problem. No problem. So that's why the main management, gamot talaga. Okay. Now, ano nangyayari? Anong gagawin natin if the patient is agitated? Okay? So, remove the cause. Okay? Eliminate the stimuli. For example, the patient is having a hallucination, no, nag-hallucinate siya. Okay? To prevent further agitation, you have to turn off the television, turn off the radios, ganyan. So walang stimuli na magkukos ng further worsening sa kanyang hallucination. Okay? Next, set limits. So when you set limits, dapat malalaman nila yung kanilang, no, the consequences of their action. Do not argue with them, no? Don't argue or criticize. 'Di ba? Anong saying na 'yon, 'di ba? Huwag patulan ang, no, may sira sa utak kasi pag pinatulan mo yung schizophrenia, ano ibig sabihin niyan? O parehas na kayo, no? Schizophrenic ka na din. So huwag patulan, do not argue or criticize. And also don't display anger. Huwag magagalit. Okay, so just set limits. And lastly, administer medications. Okay, next, if the patient is showing signs of delusion, no? Especially if it is a paranoid delusion, which is a very common, no? Isa sa mga common na delusion. Paranoid delusion. Anong gagawin natin? We have to explain all procedures. No? Explain all procedure. Okay? For example, no, sa pantry, no, ayaw niyang kainin yung pagkain na na-serve sa kanya. Anong pwede natin gawin? Pwede natin siya dalhin doon sa kusina. Siya dapat na mag-prepare, no? Siya dapat na magbubukas ng kanyang mga pagkain, etc. Para na ma-at ease siya, no? Explain all procedure. Next, kapag may paranoid, no, paranoid delusion, dapat we have to maintain proper eye contact. Okay? Kapag paranoid delusion si patient, no, ang best talaga is consistent eye contact. Pero kapag agitated siya, no, dapat intermittent. Huwag mong titignan ng diretso-diretso. Pero kapag paranoid, dapat diretso ka lang nakatingin sa kanya. Next, dapat ang actions natin are expected and consistent. No? Don't touch the patient. Huwag mong hahawakan without consent. Don't whisper. Don't laugh. Okay? And also, don't reinforce the delusion. No? Don't reinforce the delusion. Next, for hallucinations, ano daw ang ating nursing interventions dyan? No? If the patient is having hallucination, decrease stimuli and present reality. No? Identify the contributing factor. Is it the radio? Is it the TV? No? Is this too much sound, too much people, ganyan. So kung sobrang daming tao, paalisin, etc. So identify the contributing factor. Next, monitor for non-verbal stimuli. No, monitor for non-verbal stimuli. Ano ibig sabihin yan? What if nakikita mo siya na may, no, naggaganong-ganon siya, may pinapatay daw siyang lamok. So that is a non-verbal stimuli. So monitor for that one. Okay? Next, monitor for command hallucination. So ano ibig sabihin nito? These types of hallucination are usually dangerous. Bakit? Command hallucinations are usually geared towards harming others or self-harm. For example, no, Albert Einstein told me to kill you. O mga ganun. Those are command hallucinations. So, delikado siya. So, you have to watch out for those. And lastly, don't participate. No, don't participate. For example, nakita mo si patient na nagpapatay-patay daw siya ng lamok, ganun-ganon, huwag ka din lumapit tapos tulungan mo siya, no? Don't participate in the hallucination. Okay? So, any questions? Any questions sa ating schizophrenia? No questions? Okay, let's answer the following. Okay. So, a male 27-year-old admitted to the psych ward after a brief psychotic episode. Client was observed to be looking into the distance. During interview, client will not respond and remain quiet. Client often seen lying on bed. Prolonged periods of fasting also noted. Client refuses to take a bath or brush teeth. Client was seen to be playing with own feces on one occasion. Additionally, client has repeatedly stated that the food here is poison and the doctors are not my friends. Client keeps a security pillow and refers to it as his best friend. Client frequently sings himself to sleep. Client often seen looking at the mirror, drawing faces on the condensation. Client would be seen waking up early in the morning, scratching and saying that there are bugs crawling on his skin, to which no insect was observed. Okay, so for each symptoms of schizophrenia spectrum disorder, select the findings that would be appropriate for the symptoms. Each symptoms may support more than one answer. So these are all the findings, option 1, option 2, option 3, and these are all the symptoms, diba? So for option 1, para lang to sa positive. For option 2, para lang to sa negative. For option 3, disorganization. No? Ang ating i-determine lang if the finding no, is related to the positive symptom, okay, or negative or disorganized. So let's start with option 1. No? States the food is poison. Is this a positive symptom? Yes or no? States the food here is poison. Is this a positive symptom? Yes or no? Yes, di ba? Because if the patient says the food here is poison, anong tawag yan? That's a delusion. Okay, so number 1, that's correct. Next, number 2. States the doctors are not my friend. Is this a positive symptom? The doctors are not my friend. Hindi naman, no? Hindi ibig sabihin na hindi niya friends yung doctor niya, meron na siyang delusion, hallucination, whatever. Next, refers to the pillow as best friend. Ang tawag niya sa kanyang pillow is best friend niya daw yan. Is that a positive symptom? Answer is, ang tawag niya sa best friend niya, ay ang tawag niya sa una niya kay best friend niya daw. It is a positive symptom. Anong tawag natin dyan? When you misinterpret. Yes, very good. This is what we call as an illusion. O last, scratches the skin stating there are insects. Positive symptom ba yan? Yes. No, anong tawag natin dyan? Wala namang nakikita, siya lang nakakakita. That's what we call as a hallucination. Correct. O next, negative symptom naman tayo, option 2. Often seen lying on bed. Lagi lang daw nakahiga. Is that a negative symptom? Answer is yes. No, we call that as your anergia. Walang energy. O next, prolonged periods of fasting noted. Hindi kumakain. Answer is yes. Anong tawag natin dyan? Anorexia. Very good. Anorexia. Does not respond to interview and remains quiet. Hindi nagsasalita. Answer is yes. Alogia. Okay, last. Refuses to take a bath or brush teeth. Wala siyang self-care activity. Correct answer? Yes. Avolition. There is no motivation for self-care. Next, disorganized symptoms tayo. Looking into the distance, is that an abnormal behavior? Looking into the distance. Nakatingin sa malayo. Grabe naman to. Bantay lang kayo ha, kung hindi kayo nakatingin sa malayo. No? Nakatingin kayo sa malayo, tatawagin ko yung schizophrenia. No ang answer, of course. Okay? Sometimes we do this, di ba? No, pag stress ka sa trabaho, tapos nag-iisip ka, magre-resign na kaya ako, tapos malayo yung tingin mo. Oh. So, hindi naman yan schizophrenia agad. Okay? If di makasagot, no, lutang. Oh, tignan nyo, pag titake nyo ng NCLEX exam, nakatingin ka na sa malayo. Oh, iniisip mo yung answer. Okay, next. Playing with own feces. O yan. Is that an abnormal behavior? Yes. No, ito talaga yung abnormal, no? Unless na ginagawa mo to, no? Hopefully hindi. Okay, next. Singing self to sleep. Kumakanta siya hanggang nakatulog. No, hindi naman to abnormal. Okay, next. Looking at the mirror, drawing faces on the condensation. Nakatingin siya sa salamin, tapos nagdo-drawing daw siya sa salamin. Okay, very good. The answer is no. No? Sometimes ginagawa din natin to, di ba? Naglalakad ka sa parking lot, tapos pagtingin mo, no, hindi hinugasan yung kotse. Tapos anong gagawin mo? Diba? Drawing ka ng titi kasi wala kang treat. Tapos tawa ka, hehehe, tapos alis ka na. Okay? So, common naman siya. Ginagawa naman to ng mga normal na tao. Okay, next tayo. A client was recently released from wrist and ankle restraints. Suddenly, the client begins to beat the sheet and yell, "Get those bugs away from me. They are all over me. Get them." The best initial response by the nurse is, number 1, what kind of bugs are on you? Number 2, don't worry, those are just little bugs. They won't hurt you. 3, you're seeing bugs because you are sick. I don't see any bugs. 4, just hold very still and the bugs will crawl away. So ano yung best answer dyan? Malamang number 3. 1, 2, and 4 are all participating in the hallucination. Diba? Do not participate with the hallucination. Number 3 is the best answer. Okay? A client newly admitted to the facility with the diagnosis of schizophrenia tells you a story, no, that he was walking down the corridor at work and saw 2 friends talking and laughing. Sige. Yes, correct. Present reality, no? No, there is no bugs, no? Yan, present reality siya. Okay, so walking down the corridor at work and saw 2 friends talking and laughing. He assumed that they were talking about him, but was willing to consider other reasons for their conversation. A client has expressed a symptom known as, okay, sabi niya na pinag-uusapan daw siya. Okay? Very good. It's a delusion of reference, no? Delusion of reference. Hindi siya pwede hallucination because hallucination is a sensory experience without stimuli. Meron naman siyang stimuli, nakita niyo naman. It's not misinterpretation because it's more of a thought, no? He assumed, so ibig sabihin thought siya. Okay? And hindi din siya depersonalization because this is a different disorder. Okay. Negative symptoms of schizophrenia are to social withdrawal, akathisia, and apathy. While positive symptoms are to, ano daw yung mga positive symptoms? Is it number 1, delusion, flight of ideas, aloofness, 2, anergia? Okay, the correct answer is, sige, ano? Very good, the correct answer is number 4. Okay, sensory distortion delusion and misinterpretation of external stimuli. Sensory distortion, hallucination, delusion, misinterpretation, illusion. Okay? Hmm. So, antipsychotic. Game pa ba? Antipsychotics? Or break mo na 5 minutes, tas antipsychotics tayo. Break muna tayo 5 minutes, then discuss tayo ng antipsychotics. Okay lang? Okay, sige. So break tayo, 5 minutes, tapos last topic natin, antipsychotics. Okay, para next topic natin would be, tawag yung mga depression na. Okay? So break muna tayo 5 minutes. Okay, last topic, antipsychotic medications. So these are the different antipsychotic medications. Okay? So meron tayong so ang antipsychotics pala natin, no, it's general effect. Ang ginagawa niya sa katawan ng mga pasyente natin is that it decreases dopamine. Okay, yan ang ginagawa niya ha. It decreases dopamine. Aside from that, no, antipsychotics, ang other name nito is neuroleptics and also major tranquilizers. Tranquilizers. So that's another name for your antipsychotics, neuroleptics and major tranquilizers. So from the name itself, no, tranquilizer, ibig sabihin nakakaantok. Nakakaantok tong mga gamot na to. So antipsychotics are divided into two. Meron tayong typical, marami din siyang ibang pangalan, no? Traditional, conventional, it's the same thing. Typical pa rin yan. And atypical. Typical antipsychotics are usually used to treat positive symptoms, yung hallucination, delusion, illusion. Whereas atypical antipsychotics can be used to treat both positive and negative symptoms. Okay? But the effect is more usually profound on the negative. Typical antipsychotics, ang mga side effects nito is usually, no, malakas to siya sa EPS at saka mga anticholinergic side effects. So ano tong mga anticholinergic side effect? Tatandaan mo lang yung can't. Okay? Can't see, can't pee, can't spit, can't shit. So patients who are taking antipsychotics, nagkakaroon sila ng blurry vision. Nagkakaroon sila ng urinary retention, drying of the mouth, and lastly, constipation. No, ito yung mga side effects ng typical antipsychotic. EPS at saka anticholinergic side effects, yung mga can't. Okay? Now, for atypical naman, ang side effects nito is ganun pa rin, may EPS pa rin, but not as much. No? Mababa yung risk nila for developing EPS. Especially when it comes to anticholinergics. Hindi masyado sila nagkakaroon ng anticholinergic side effects. Okay? Ang anticholinergic side effect, common talaga to sa mga typical antipsychotics. So let's meet the medications. Ayan. So ito yung mga gamot natin. We have your typical here, atypical there. Ang typical natin are divided into three: high, moderate, and low potency. No? High potency typical antipsychotics, mas matibay yung kanilang mga extrapyramidal symptom side effect, EPS. Whereas ang low potency, no, mostly ang nakikita sa kanila is yung anticholinergic side effects. Okay? So ano-ano itong mga gamot na to? Under your high potency, we have your Prohanastella, Prolixin, Haldol, Navane, Stelazine. Moderate naman, Lomotril, L'Occitane, Moban, Trilafon. And sa low potency, Tosetame, Torazine, Serentil, Talactan, Melaril. Okay? So these are, no, a quick way of remembering this medication. In your own time, no, basa-basahin nyo paulit-ulit para ma-memorize. For atypical antipsychotic, madali lang. Clorizol, Clozaril, Risperidal, at saka Olanzapine. Clorizol. Okay? So, let's discuss mga common side effect or common nursing interventions natin with specific typical antipsychotics. Okay, first would be your mga high potency, no, Prolixin at Haldol. Pag-usapan natin to sila. Okay? Prolixin, no? Under Prolixin, meron tayong gamot na tinatawag flofenazine decanoate. Flofenazine decanoate is usually used for those who are non-compliant, no? Kasi long-acting yung effect nito. long-acting, mga 2 to 3 weeks. So ginagamit to siya for non-compliant patients. Okay? Haloperidol decanoate, ganun din. It is a long-acting, commonly used for non-compliant. Okay, so kung nakita mo tong word na decanoate, no, sounds like they can wait, no? Kayang maghintay kasi long-acting yung gamot. Okay? Haloperidol plus benzo are commonly used to treat aggressive psychotic patients. Yan. Oh, next, thorazine. Okay? Thorazine, no, or yung another name niya is chlorpromazine. This is usually given to children with behavioral problems. Okay? Not necessarily for children who are psychotic, pero may mga behavioral problem. Okay? Side effect of this medication, it causes photosensitivity. No? Photosensitivity or can't see. Can't see. Usually, no, pag malakas yung light, madali silang nabubulag. Okay? Can't see. Or next, serentil. Serentil causes cardiac arrest. It can cause cardiac arrest. So that's one of its adverse effects. Last, melaril or thioridazine. Thioridazine, binibigay ito sa mga bata, again with behavioral problems, because it can cause a calming effect. Nakakakalma siya. However, if you give this medication greater than 800 milligrams per day, it can start causing retinopathy. Okay? So, if a patient is taking melaril or thioridazine and starts complaining, tawag yan, problems with vision, you have to stop the medication kasi baka may retinopathy na sila. Okay? As a general rule, when it comes to your antipsychotics, no? Typical ba yan or atypical? Tolerance usually develops at around the 3rd month. They start tolerating the medication. Okay? If the patient, no, has an EPS, extrapyramidal symptom, you have to treat it by tapering, no, binabawasan or discontinue. They either taper, babawasan, or they stop the medication altogether. Next, no, as a general rule, doctors would want to use drugs, no, with the lowest, no, signs and symptoms for EPS. Yan. Okay, so these are common nursing consideration with specific typical antipsychotic. Let's go to common nursing consideration with atypical antipsychotics. First, your clozapine. Your clozapine or clozaril, parehas lang yan. Okay? This medication can cause agranulocytosis. It can cause agranulocytosis. So you have to watch out for early signs of infection. Ibig sabihin, if the patient has sore throat, no, nagkakaroon na ng sore throat. If the patient starts to develop a fever, that could be a sign of agranulocytosis. So you have to stop the medication. Additionally, no, if you give the medication 600 to 900 milligrams, it can start a seizure. No? Pwede na siyang makakause ng seizures. Yes, burning urination, another sign, no, of early infections. Fever, sore throat, burning urination, these are signs of early infections. Okay na? Let's continue. Okay. Next, risperidone at saka olanzapine. Okay? Now, with risperidone and olanzapine, no, usually wala to siyang EPS. But the more you increase the dose, the higher the dose, the more you can cause an EPS. Risperidone and olanzapine is long-acting. It can cause orthostatic hypotension. It can also cause sedation, nakakaantok. Okay? But higher doses No? Kapag sobrang taas yung dose, it can cause insomnia as well. And lastly, your aripiprazole or yung tinatawag ngayon sa market as Abilify. Now, this one is what they call as novel antipsychotic kasi makabago siya, no? What is good about this medication is that it is a dopamine system stabilizer, meaning this medication is smart enough to increase or decrease dopamine levels, no? Increase or decrease dopamine levels depending on the serum. So, if a patient has psychosis, meron siyang schizophrenia, tas iinom siya ng Abilify, the medication will decrease it. No? Will decrease dopamine. Okay? Pag sobrang baba na naman, the medication will increase it. So, it increases or decreases itself depending on the serum level of dopamine. Okay? Abilify or aripiprazole has virtually little or no side effects. Wala masyadong side effects tong mga gamot na to. However, this one is expensive. So, normally, no, ang iniinom ng mga patient natin is nasa Clorizol lang when it comes to atypical. Clozapine, Risperidal, Olanzapine. Okay. So, let's talk about ano tong EPS na paulit-ulit kong minimension. EPS, or what we call as extrapyramidal symptoms, are side effects commonly seen when you take antipsychotics. Bakit nagkakaroon ng EPS ang pasyente? It's because dopamine is decreasing. Okay? EPS occurs kasi yung dopamine sobrang baba, tapos yung acetylcholine tumataas. Ganyan. So that's why nagkakaroon sila nito. So what are these types of EPS? So madami. Our first would be your acute dystonia. Acute dystonia is manifested by muscular rigidity. Tumitigas yung mga muscle. No? We have different types of acute dystonia and it can show itself in different body parts. Pwede ka magkaroon ng torticollis or stiff neck tulad nito. Torticollis. Okay? Pwede ka magkaroon ng oculogyric crisis or your eyes are just contracted upwards. Lagi ka lang nakatingin sa taas. Like this one, oculogyric crisis. Okay? You can also develop writer's cramp. No? Magka-cramps yung kamay mo. Laryngeal pharyngeal spasm. This is a rare but a life-threatening form of acute dystonia. Yung muscle contraction na sa larynx mo. So it can affect the airway. Other example would be opistotonus, like this one, or a contracted back. So it can appear in different parts of the body. Basta tatandaan natin, it is muscular rigidity in different parts of the body. Okay? So what is our intervention? Our intervention is anticholinergic medications. Bakit? What is the effect of this medication? The main effect of your anticholinergic medication is that it decreases acetylcholine, which in turn increases dopamine. So parang binabalance out niya yung dopamine level ni patient. So drug of choice would be cogentin or benztropine. No, binibigay natin IM. Diphenhydramine, another medication, binibigay natin IM. And lastly, stay with the client. No, because acute dystonia can sometimes be painful, masakit, para siyang cramps, no? Parang cramp siya. It can be painful and it can be frightening kasi hindi alam ni client kung ano nangyayari sa kanya. Okay, but it can be treated with anticholinergic medications. Okay, so next tayo. Any questions dyan? Okay, so next. Another EPS would be your pseudo-Parkinsonism. So pseudo-Parkinsonism, parang Parkinson's. Okay? So ano yung idea mo sa Parkinson's disease? Ganun din dito. So bakit sila nagkakaroon ng pseudo-Parkinsonism? Again, sobrang baba ang kanilang dopamine. Tulad sa Parkinson's, di ba? Parkinson's disease, it's because they have decreased or very low dopamine levels. So pseudo-Parkinsonism is common to those who are dehydrated, to those who are elderly, and sa mga babae. No? It appears 1 week after treatment. Signs and symptoms ito, tulad ng Parkinson's. There is tremor, no? Shuffling, okay? There is cogwheel rigidity. So, kung ano yung idea mo sa Parkinson's, ganun din, no? Nandito din yan siya. So, what is the intervention? Okay, so doctors can either change the medication, taper it, bawasan, or they can give anticholinergic medications na naman. Amantadine. So, ano ginagawa ng amantadine? Well, it increases your acetylcholine, which in turn decreases, no? Ang ginagawa nito is that it is modulating the dopamine. So, pinapababa niya si acetylcholine para tumaas si dopamine. So, mida-balance niya na naman, no? Balancing act lang talaga to. Okay? Next, akathisia. Now, akathisia is the most common EPS. And it is the most common reason why patients with schizophrenia stop taking antipsychotics. No? Bakit? Because akathisia, a manifestation nito is yan, restlessness, agitated, no? Panic sila. They don't understand kung bakit ganito, but they are conscious enough to notice na laging ganyan yung kanilang reaction. Okay? So what is your intervention here? Again, change medication or taper. Beta blockers. Bakit nagbibigay ng beta blockers? No? Beta blockers are vasodilators, di ba? Tatandaan natin, medications that causes vasodilation can also cause sedation, nakakaantok. That's why they give beta blockers to sedate the patient, to calm the patient. Additionally, ang mga beta blockers kasi is it is not addicting as compared to benzodiazepines. So, yan ang binibigay. No? Medication under this one would be your propanolol. No? Propanolol. They can also give anticholinergic na naman para mabalance yung dopamine. Okay? So, next tayo. 1, 2, 3. Ayan. Next natin is tardive dyskinesia. So, ang tardive dyskinesia, this one is late appearing and irreversible. Mahirap na tong tanggalin. This is manifested by stereotype movements tulad nito. Tongue protrusion, face grimacing, lip smacking. No, we have to understand that these behaviors are unconscious. So, hindi nababantayan ni patient. No, hindi niya nababantayan na ginagawa niya na pala to. No, pakindat-kindat siya, hindi niya alam bakit. Okay? Or hindi niya nababantayan. So, what is our interventions with this one? Okay? So, stop antipsychotic, decrease dose or change med, monitor the clients kasi hindi masyado ito natatanggal, or they can give valbenazine. Valbenazine, no, is a drug of choice commonly ginagamit natin for tardive dyskinesia. No, kaya niyang tanggalin itong condition nito. Okay? However, once it appears, mahirap nang tanggalin. No, mahirap nang tanggalin si tardive dyskinesia. And last but not the least, RNMS. RNMS is the most lethal, tatandaan ha, most lethal form of EPS. Manifestation nito, lahat tumataas. Everything is going up. Fever, no? Muscle rigidity, altered LOC, restless sila, hyperactivity, so increase deep tendon reflex, increase RR, pulse rate, BP, everything is going up. So that's the manifestation of neuroleptic malignant syndrome. Pero ang kanyang cardinal sign is fever plus muscle rigidity. Sabay talaga ito sila. Yes, no, valbenazine, ito yung drug of choice for tardive dyskinesia. Okay? So bakit to siya lethal? Because nakakamatay siya. What actually kills the patient is the fever. ito yung nakakamatay. So bakit siya nagkakaroon ng fever? Because all the muscles in the patient's body is contracting, which is generating heat. So pag mainit yung katawan niya, mag-shoot up yung temperature. So that is why no, ang ating tawag yan, step by step natin na treatment or nursing intervention for a patient showing signs of malignant non-neuroleptic malignant syndrome is number one, discontinue lahat ng gamot. No, kung ano yung iniinom niya, you have to stop it. Next, you have to treat the fever. So you have to lower the fever. And how do you lower the fever? No? External cooling measures. Okay? So ang recommended is cooling blanket para bumaba yung kanyang temperature as soon as possible. Okay? Kasi kung tataas yan ng tataas, pwedeng makamatay. Okay? Yes, cooling blanket. Yan daw yung the best. After nyan, no, after bumaba yung fever niya, the patient is now going to the ICU. No? But of course, kailangan mo stable mo na si patient. So dapat replaced ang fluids as much as possible kasi pinagpapawisan to sila. Okay? Pag nasa ICU, doon na nagbibigay ng muscle relaxants. So ang drug of choices natin para dito is dantrolene or no, benzodiazepine. No? Dantrolene and benzo decreases no, muscle rigidity. So pag nawawala yung muscle rigidity, nakokontrol na din yung fever. No? Huwag bibigyan si patient ng antipyretic because it will not work. No, antipyretic will not work. The drug of choice will be dantrolene or benzodiazepine. Okay? And lastly, no, after that, monitoring na to si patient. Doctors might give anticholinergics no, to balance out dopamine, but it will depend. Pero ito yung step-by-step process. No? Dapat discontinue lahat ng gamot, fever, external cooling measures, no? Cooling blankets, transfer to ICU, dantrolene and benzodiazepine, and monitor vital signs. Amantadine, pwede cogentin, yung binibigay basta usually anticholinergic, yung binibigay to balance out the dopamine. Okay? So it usually depends on the physician. Okay? Pwede benztropine o cogentin pa rin yan. So, okay, other side effects ng mga antipsychotics natin would be, so next slide na tayo ha, 1, 2, 3, o yan. So other side effects would be sedation, di ba? Because antipsychotics are tranquilizers, so nakakaantok. So that's why it is best given at night, no? Kung kailan matutulog ka na. Next, atropine psychosis. So ibig sabihin, no, the patient can start to show atropine psychosis. Anong manifestation nito? Red as a beet. So pulang-pula yung skin nila. Dry as a bone. Ibig sabihin, their skin is very dry and mad as a hatter. So nagkakaroon na sila ng psychosis. Okay? So another side effect of antipsychotics. Next, photosensitivity. So kung meron photosensitivity, how do we treat this one? Sunglasses, di ba? O pwede sila magsuot ng sunblock or mga long sleeves. Yan. Anticholinergic side effects, na-mention na natin to can't. Can't see, can't pee, can't spit, can't shit. Agranulocytosis, no, common sa clozaril or clozapine. Okay, common sa clozaril. Okay? Usually, if the if the WBC is less than 3,000, dinidiscontinue na nila yung gamot. Okay? Seizure, again, common sa clozaril. Okay? So, pag 600 to 900 milligrams na yung dosage, nakakaroon na sila ng seizure. Orthostatic hypotension, yes, no, another common side effect. No, the BP usually falls down, no, pag tumatayo. Okay, and lastly, hormonal effects, no? So, for men and women, magkaiba. For male patients, nagkakaroon sila ng retrograde ejaculation. Retrograde ejaculation. Okay? So retrograde ejaculation is retro, no? Pabaliktad yung nagba-backflow yung kanilang ejaculation. Okay, for example, kung ito yung penis nila, di ba ganyan? It's bladder. Okay? So, a retrograde ejaculation is yung kanilang ejaculation. Instead na lalabas pa ganyan, it goes back and then pupunta sa bladder. Okay? Bumabaliktad. Goes to your urinary bladder. Okay? For women, they show signs of amenorrhea. No? Amenorrhea. Okay, so, ang ating nursing intervention dito, no, we tell them that it is reversible. Nawawala lang dito eventually. And that they should continue contraception. Kasi it goes away. No, hindi ibig sabihin na forever na sila na may retrograde ejaculation or amenorrhea. It goes away eventually. So continue contraception pa rin. Okay, so before we end tonight, let's answer this question, no? Click to highlight the findings that reflect understanding of medication and condition. Okay, so naka-highlight na, may number na lang. So babasahin na lang natin. Okay. So Redwood National Park, male 27 years old, admitted to the psych ward after brief psychotic episode, diagnosed with schizophrenia. Client was prescribed with prolixin to treat positive symptoms and clozaril for negative symptoms. The client was observed to be stretching his muscles, stating, number one, that he is watching out for muscle stiffness and fever, and to report it to the HCP if any symptoms show. Does number one reveals understanding or reflects understanding? Correct. No? Kasi alam ni client that if meron siyang fever and muscle stiffness, baka meron siyang ano yung most lethal EPS natin? Most lethal EPS, very good. NMS. Okay, next. Number two. Number two, the client added that he felt symptoms of stiff neck, backaches, and hand spasm, stating they are signs of NMS. Does that reflect understanding? No. No? Ano tong stiff neck, backache, and hand spasm? That's your tardive dyskinesia. No? Tardive dyskinesia pala yan. So, mali. Number three, the client states that akathisia has now disappeared, stating that that is the sign of neuroleptic medication effectivity. Tama ba si number three? Nawala na daw si akathisia, ibig sabihin effective daw yung kanyang neuroleptic medications. Answer is no. Kasi kung effective yung neuroleptic medications niya, dapat ang mawawala is yung hallucination, delusion, negative symptoms, ganyan. Hindi mawawala si akathisia. Akathisia is just a side effect, no? So if it goes or comes, it doesn't matter. It does not mean that the medication is effective or worsening. So mali din si number 3. During periods of outdoor activities, client was observed to be participating with other clients well. Number 4, the client was observed to be wearing sunglasses during activities. Does that reflect understanding? Correct. Kasi alam ni client, photosensitivity is a side effect sa kanyang gamot. Very good. During lunch, UAP reported to the nurse that the number 5, client ate 2 pieces of fried chicken, 4 strips of bacon, mashed potato, and bread pudding. Does that reflect understanding? Yung mga kinain niya. Answer is no. No? Dahil sa anticholinergic side effect na can't shit. No? Constipation is a side effect of the medication, so the client should not be eating low fiber diet or magwo-worsen yung kanyang condition. So mali si number 5. Later, the number 6, client was seen sucking on ice and chewing a sugarless gum. Does that reflect understanding? Answer is yes. Can't spit. Diba? Can't spit to. So, ibig sabihin, drying of the mouth. So, sucking on ice, chewing on sugarless gum, para hindi magdadry yung mouth niya. Okay, so bumalik na sila sa kanilang rehab center. Upon returning, number 7, the client visited the nurse's station after taking a short nap, stating that he has a sore throat and dry cough. Does that reflect understanding the medication or condition? Answer is yes, because the client is taking clozaril, and a granulocytosis is a side effect of the medication. No? So, ibig sabihin that is correct. An early sign of infection. And with that, we are done with the first part of psych. Okay? So, any questions before tayo matulog? Sir, papass through po ng konti sa ECT. Lumabas kasi po sa practice test. Electroconvulsive therapy, discuss natin tomorrow. No? Pag magdi-discuss na tayo ng mga depression, bipolar disorders kasi no, nandoon naman yung ECT treatment. So, any questions before we say good night to each other? No questions? Okay, so good night. And I'll see you tomorrow. I hope that you learned something today at hindi lang natutunan, dapat nag-retain din sana. So see you tomorrow and we will continue with depression or mood disorder. So bye-bye, ingat po kayo.